So, good morning to everybody. I welcome you all to this workshop organized by the Department of Pediatric and the Department of Nephrology to celebrate the World Kidney Day 2022. And I thank all the delegates for participating in this great program. As we all know, the theme for World Kidney Day this year is kidney health for all. And the approach which has been advocated is by bridging the knowledge gap to better kidney health. It is increasingly acknowledged that there are multiple levels of knowledge gap in kidney care is concerned. And we can see that levels of knowledge gap exist at multiple levels, such as the community health level, where we have limited health literacy, the healthcare worker level, and also the public health policymakers level, where political commitments on non-communicable disease concentrate chiefly on cardiovascular diseases, cancer, diabetes, and chronic respiratory disease. So the idea is to bring together the community for kidney health to bridge the knowledge gap. And hence, we're organizing this workshop on pediatric hemodialysis by the Department of Pediatrics and the Department of Nephrology on one of the smart initiatives. Uh, so today we have three sessions. The first session is chaired by Professor Arvind Bakasar, the professor and head of department Department of Pediatrics at All India Institute of Medical Sciences in Delhi, and Dr. Anu Anand, who is a consultant pediatric nephrologist, Division of Pediatric Nephrology and Renal Transplantation at the Institute of Child Health, Satyamar Hospital in New Delhi. So welcome both of them, and I invite Satyam to speak a few words.
Good morning. Good morning, dear participants. Thank you very much for coming here for this meeting. The first session we will be covering some basic aspects of dialysis, of hemodialysis. First talk is on maintenance hemodialysis in children, and it's my pleasure to introduce Dr. Professor Manish Kumar. So Manish is Professor of Pediatrics at Chacha Nehru Bal Chikitsalaya. He's been there for almost now more than 15 years now, 14 years, yeah. And he's been instrumental in strengthening pediatric hemodialysis services in the city. I think there are multiple centers that are providing hemodialysis, but Manish's center has been very consistent and has always been there. So thank you, Manish, for this for being here. And we invite you to speak on maintenance hemodialysis principles in children. Thank you very much.
Very good morning to all of you. Thank you, sir. Thank you for your kind words. And at the outset, I must thank Dr. Dhakkar, Dr. Aditi for inviting me for this dialysis workshop. So, for next 20 minutes, I will be talking about maintenance hemodialysis in children. So, it's a technique of extracorporeal removal of excess water and waste products using a hemodialysis machine and a dialyzer. And is the most common modality of renal replacement therapy, often serves as a bridge therapy in children who are waiting for the renal transplantation. So globally, around 4 million people are on renal replacement therapy, and hemodialysis accounts for the majority of the modes of renal replacement therapy. Roughly 69% of RRT is contributed by maintenance hemodialysis, and 89% of all diuretic mode is contributed by hemodialysis. So according to an estimate, in India, roughly 175,000 patients are on chronic dialysis, giving a prevalence of 129 per million population, and out of it, 95% are receiving maintenance hemodialysis. According to the estimate, which was published in 2018, estimated number of dialysis units and dialysis machines in India are around 1,600 and 16 and 13,000 respectively. So very little amount that to meet the demand of the dialysis in our country. So now coming to the indications for initiation of dialysis, there is no consensus on optimal timing for starting dialysis. Though KDOP guidelines in 2006 suggested that RRT in children should be considered when estimated GFR falls below 14, and it's recommended when estimated GFR falls below 8 ml per minute per 107.3 meter square. So the recent update on initiation of dialysis is basically a guideline that it should not depend on the exact number of or threshold of estimated GFR, but whenever the patients develop symptoms that can be attributed to renal failure, like if the patient is having neurological features that can be attributed to kidney failure, that we often label as the ischemic encephalopathy, if the patient has pericarditis, or if there is a medically resistant acid-base imbalances, or there is electrolyte abnormalities like persistent hypokalemia, if there is a reduced energy level, weight loss with no other potential explanation, and if the patient is unable to maintain the volume status despite using the medications, or the nutritional status is not maintained, or which are reflected interventions, then in these cases we can plan to start maintenance hemodialysis. So, RCT, which was done in adults in 2010 and was published in NEGM, this was chiefly done on adults, patients more than 18 years of age, to determine or to assess the efficacy of hemodialysis, timing of initiation of hemodialysis on the patient survival. And the patients were divided into two groups: those who required, in whom hemodialysis was started between 10 to with a GFR of 10 to 14, and it was labeled as the early start of hemodialysis, and where the dialysis was started when the GFR was below 5 to 7 ml per minute per 1.7 centimeters square, and they were labeled as a late starter. So they found that there was no difference in ultimate survival, final survival of the patient, whether they were started early or late. Similarly, in a study from pediatric registry data, European registry data, where they tried to find out the association between timing of dialysis initiation and clinical outcomes in children, where close to 3,000 children less than 18 years of age who were started on RRT between 2000 and 2014. We are divided into two groups: those who were started early with a GFR of more than 8 ml per minute, and those who were started late with a GFR of less than 8. And the primary outcome was assessed in terms of patient survival and access to transplantation. So what they found that there was also no difference in ultimate outcome, the survival patients, or rate of renal transplantation in those who were started early versus late. So they concluded that no significant association of estimated GFR at the initiation of dialysis initiation with either mortality, access to transplantation, or growth after 1 year of age. So now coming to the different types of maintenance hemodialysis, and we divide that should be, or we can say that on the basis of physiological principles of dialysis, or what type of dialyzer we are using, or based on the frequency of dialysis, we can have a different types of maintenance hemodialysis. So if we are the physiologic basis is mainly diffusion, that's a hemodialysis. If the convection mode, there's a hemofiltration, and if there's a combination of dialysis, diffusion and convection, this is hemodiafiltration. That we will coming on the physiologic basis of dialysis in the next slide. So based on the dialyzer efficiency, if you are using high flux dialyzer, then it's called high flux hemodialysis. Normally we use the low flux dialyzer for the maintenance hemodialysis. But with high flux dialyzers, there is a better clearance of metal molecules because of larger pore size of the dialysis membranes, and that results in a better efficiency of dialysis. Based on the efficiency of dialysis, conventionally we are using thrice weekly hemodialysis with 4-hour duration of each session. But the frequent dialysis is where we dialyze more frequently, that is in the form of short daily dialysis, that means 5 to 6 days of week of 1.5 to 2 hours of daily dialysis duration, or nocturnal hemodialysis, where the patient is given the facility of dialysis during nights of 5 to 6 hours per session, and over 5 to 6 days of week. So now coming to the physiological principles of dialysis, there are chiefly three mechanisms by which dialysis occurs: the diffusion, ultrafiltration, and convection. So diffusion is the mechanism where the solutes move from higher concentration gradient to the lower concentration gradient across the semi-permeable membrane, and it depends on the size of the molecules. So if the solutes are smaller in size, there is a probability that it will move more rapidly, it will collide with the membranes more frequently, and there is a probability of transfer of molecules across the membrane. So we can see easily from this diagram also. So this compartment shows the blood. This is the dialysate. So normally in renal failure patients, there is a higher concentration of blood urea. So this blue dots is indicative of urea, which has higher concentration in the blood, whereas dialysate doesn't have any urea component. But in dialysis, there are bicarbonate. So when during dialysis, with diffusion, urea comes from blood to dialysate, and bicarbonate comes from dialysate to blood. So this way the diffusion works. The second mechanism is ultrafiltration, where there is a movement of water across the semi-permeable membrane driven by either hydrostatic pressure or osmotic pressure. So in hemodialysis, this hydrostatic pressure works, and this is the pressure generated across a dialyzer membrane between the blood and dialyzer compartment. So this leads to movement of water across the dialysis membrane. Third is a convection. So during ultrafiltration, this movement of water, there are small molecules that also move along the semi-permeable membrane. This is also called solvent drag, and this doesn't depend on the concentration of the molecule. So these are three mechanisms of dialysis. Irrespective of dialytic modality, whether it's a peritoneal dialysis or hemodialysis, always there is a three mechanism. So based on which is the key mechanism of dialysis, if there is a main modality of movement of the molecules of dialytic modality is diffusion, that's called hemodialysis. If principally it's convection, there's a hemofiltration. And if there is a combination of diffusion and convection, then it's a hemodiafiltration. That's a combination of hemodialysis and hemofiltration. So coming on the benefit of hemodiafiltration, there was one study which was published in 2018, and this study assessed the benefit of hemodiafiltration in comparison to hemodialysis. So this was an observational study, and they found that hemodiafiltration, there was no progression of vascular changes. We can see that the carotid intima media thickness, the patients who are on hemodialysis, there was increase in carotid intima media thickness over a period of 1 year in the follow-up. Whereas those patients who were on hemodiafiltration, there was no change in carotid intima media thickness. In addition to this, vascular outcome, patients also had a better increase in height standard deviation score. There was better control of blood pressure. There was better clearance of beta-2 microglobulin, and better parathormone maintenance, and also the hemoglobin was maintained better in those patients who were on hemodiafiltration. So now coming to the prerequisites of pediatric hemodialysis, this is technically more complex in comparison to adult hemodialysis because it requires a multidisciplinary team needing a pediatric nephrologist, dialysis nurse, dialysis technician, interventional radiologist, because you need a fistula creation for maintenance hemodialysis. Also, we need a dietitian and clinical psychologist because it's completely different than the adult hemodialysis. The components of hemodialysis are a hemodialysis machine. You need a water treatment unit that we will discussing in our next session about the machine and the water treatment unit. Dialyzer and tubing, vascular access, and also dialysis prescription. So this is a hemodialysis machine at our center, and the hemodialysis circuit has a circuit which starts from the venous end of the patient. The blood go through the pump, then dialyzer, and again comes back to the patient to the venous end. In dialysis circuit, it's help in the mixing of acid and bicarbonate concentrate to make the final dialyzer to be delivered to the dialyzer. Then the machine has monitors and ports also. So coming to the dialyzer and tubing, this is the very important part of hemodialysis because together they form the extracorporeal circuit. And the dialyzer is the interface of the blood and dialysis solution circuit, where it's made of thousands of capillaries inside the dialyzer. This is the cross section of the dialyzer, which shows the thousands of capillaries in which the blood flow, and surrounding these capillaries the dialysate flow. So blood and dialysate flow in the opposite direction. So if the blood flows in this direction, the dialysate flow in the opposite direction, and this is useful for the efficient hemodialysis, as we already discussed, the physiologic principles of hemodialysis, the diffusion is across the concentration gradient. So because the blood and dialysate moves in the opposite direction, it helps in maintaining the concentration gradient throughout the period of dialysis. So that's the importance of moving blood and dialysate in the opposite direction. Now coming to the dialyzer specifications, we should know what this dialyzer, what are the dialyzer specifications. So whenever we use a dialyzer, we should see the catalogs that is supplied with the dialyzer, and it has all those specifications that we need while making a dialysis prescription. So these specifications are dialyzer membrane. So nowadays all dialyzers are with this biocompatible synthetic membrane, because earlier they used cellulose membrane that was somewhat incompatible, leading to the complement activation and reaction. So nowadays almost all dialyzers they have the synthetic membrane. The next for dialyzer specification is the surface area that roughly varies from 0.8 to 1.3 meters square. And we are using a dialyzer for a patient. Normally we keep in mind that the dialyzer surface area should be around one that should be 70 to 100% of the body surface area of the patient. The third specification that we see on the dialyzer sheet or the catalog supplied with the dialyzer is KUF, that is the ultrafiltration coefficient, and this indicates the volume of plasma water that is filtered across the membrane per hour. So if the dialyzer is a high KUF, that means the more efficient dialyzer or the high flux dialyzer. Then clearance is very important part of the dialyzer that is also denoted by KD, and this clearance indicates the solid clearance of the dialyzer, and it's referred as the volume of blood from which a solid is removed per unit time during its transit through the dialyzer. So it roughly indicates how much blood is cleared of the solute. And normally, when we are talking about the solute, we are mainly talking about the low molecular weight solute in terms of urea. So, by dialyzer clearance, for the specific dialyzer clearance, we mean that how much of blood is cleared of urea when it is passing through the dialyzer per unit of time. So, this is the clearance of dialyzer. So, whenever we are making a prescription of dialysis or checking the adequacy of dialysis by calculating KT upon V, we need to know what is the clearance of the dialyzer. Then KOA, this is the mass transfer area coefficient, and this is the maximum theoretical clearance of dialyzer at infinite blood and dialysate flow rate. So every dialyzer has a KOA. So we can better understand the concept of KOA and dialyzer clearance by seeing this graph. So this graph shows on this horizontal line, this is a blood flow rate, and this indicates on the right side is the KOA. So each dialyzer has mentioned on its catalog about the dialyzer, that is the KOA or the maximum dialyzer mass transfer coefficient of the dialyzer. So the high flux dialyzer normally has a KOA of more than 600-700. So we can see that at the low blood flow rate, if the blood flow rate is around 200, irrespective of the KOA of the dialyzer, whether it's a high efficiency, high flux dialyzer or low flux dialyzer, the clearance is not very high. So if the blood flow rate is 200, even a 400 dialyzer with a KOA of 400 or with a 800, there is hardly any difference of KOA. But if the blood flow rate increases, if it comes from 200 to 300 or 350, with the dialyzer of high KOA, the clearance increases. So that's the importance of knowing the KOA, the blood flow rate, and the dialyzer clearance. So dialyzer clearance depends on one is the blood flow rate. The higher the blood flow rate, the better will be the clearance. Then dialyzer flow rate. Here we have kept the dialyzer flow rate at 500. Most of the time it's constant at 500 ml per minute, and the efficiency of dialyzer, that is KOA. So by this graph, we can determine the effective clearance based on the blood flow rate and the KOA of the dialyzer. Now coming to the frequency of dialysis, conventionally we dialyze patients or patients who are maintenance hemodialysis. It's thrice weekly, and this is the minimum that is recommended by KDOC. Nowadays, there is a trend, or the studies have shown that if you dialyze more frequently, that will help in a better control of volume status, better control of blood pressure, and the better control of phosphorus, or less cardiovascular events, the patients who are getting dialysis frequently. So this could be provided either in terms of short daily hemodialysis, that's dialyzing the patient for 1.5 to 2 hours per day for 6 days a week, or it's the nocturnal hemodialysis where the patient receives dialysis during night for 6 to 10 hours per session, 5 to 7 days a night. That also depends on the patient's preference. So guideline regarding the frequent and long duration hemodialysis, the KDOQI guideline, hemodialysis adequacy guideline, which was updated in 2015, and there was a suggestion that patients with end-stage kidney disease should be or can be offered in-center short frequent hemodialysis as an alternative to conventional twice-weekly hemodialysis, and they should be told about the potential quality of seeing the and the advantages of this daily hemodialysis for short duration, and also the risk of these therapies. Because if you provide daily hemodialysis, suppose if you are giving a thrice weekly hemodialysis and you are changing dialysis to 6 days a week, then definitely the patients are the patient is coming to dialysis unit more frequently. There was more use of vascular access, and also there is more increase in changing order of the vascular access. Might be these patients will be requiring more frequent change of vascular access. So all these things should be explained to the patient, advantages and disadvantages. Now coming to the vascular access, and this is the most difficult and most important part of maintenance hemodialysis. So despite fistula first initiative in adults, in children we are still using central venous lines as the first choice in maintenance as a maintenance hemodialysis. So data from the IPH and registry, the International Pediatric Hemodialysis Network registry, where more than 5 million children from 27 countries were prospectively followed up between 2012 and 2017, and they found that AV fistula as the first choice of vascular access was seen in only 26%, with the remaining formed by the central venous lines. On a positive note, however, on a European registry, where 713 pediatric patients on hemodialysis were assessed, and their utilization of AV fistula as the first choice of vascular access was more than what we saw in IPH and registry, and it was 45%. Compared to 55% who received central venous lines, dialysis through central venous lines. So age is not the only factor which decides the use of arteriovenous fistula or central venous line as the first modality of choice of choice of vascular access, because we can see here, despite the bigger child, even in children more than 10 to 15 years, the proportion of children who required central venous lines as the first choice of vascular access was higher than those required central venous lines. Also, the patient, also there was a higher probability of access replacement in those who received central venous lines as the first choice of vascular access in comparison to those who used arteriovenous graft or arteriovenous fistula. So, regarding the guideline for the vascular access in children, KDOQI guidelines suggest that AV fistula in children more than 20 kg and were unlikely to receive transplant within 1 year. So, a consensus document by the European Society of Pediatric Nephrology Dialysis Working Group regarding vascular access in children requiring maintenance hemodialysis, there was suggestion that children requiring chronic hemodialysis should be started with a functioning AV fistula where appropriate. However, the cuffed central venous lines, they stress that the central venous line should be a cuffed type, not a normal what uncuffed we use in the acute for the acute hemodialysis. So cuffed central venous lines for very small children, depending on the vessel size and surgical expertise, or those requiring urgent or unplanned hemodialysis. Also, the patient preference should be taken into account, because many patients they prefer central venous line because there is a apprehension regarding the for the hemodialysis, if the dialysis is done with use of a fistula because of repeated pricks, or where there is a short period of hemodialysis anticipated before renal transplantation. However, there is no evidence to provide recommendation about the arteriovenous grafts in children. So while the venous access, the first choice should be a right internal jugular vein. It's the most preferred site. And we should not use subclavian vein as a first choice because there is a very high risk. In addition to the complications associated with subclavian access, there is also very high risk of vascular stenosis with subclavian vein. If you use subclavian vein as the vascular access for maintenance hemodialysis, and that will include the further use or requirement of creation of a fistula because of stenosis. So there are definitely benefits of AV fistula. It provides a better dialysis adequacy. There are lesser infection rate, lesser risk or lesser chances of hospitalization, and also a better access survival time in comparison to CVS that we have already seen in the IPH and registry data. But there are also some disadvantages with arteriovenous fistula. This is technically more challenging in smaller children. There is increased waiting time after creation of AV fistula. You can't start dialysis right away after creating a fistula. You need a minimum 4 to 6 weeks of time before you start hemodialysis, and also you require a vascular surgeon and interventional radiologist. You need a dialysis nursing expertise, and also we should keep in mind the patient's concerns regarding puncture pain. Although we have a separate session on hemodialysis prescription and dialysis adequacy, I would like to discuss in very short about the components of hemodialysis prescription. So whenever we are writing a hemodialysis prescription of a specific patient, we need to take a dialyzer appropriate to the body size of the patient. So the dialyzers are should be of membrane should be made of synthetic component, and if we use a high flux membranes or high flux dialyzers for dialysis, the water quality should be of very good quality, because the high flux dialyzers have a membranes of a bigger pore size, and there are high risk of infection if we don't use a better quality of water. The size of dialyzer is approximately equal to the body surface area, and we should keep in mind that if we are using a dialyzer, the combined extracorporeal volume of dialyzer and tubing should not exceed 10% of the total blood volume, that is around 80 ml per kg. So that we need to keep in mind. So if the extracorporeal volume exceeds the 10% of the total blood volume of the patient, then the tubing or this extracorporeal circuit should be primed with either normal saline, blood, or 5% albumin. Then comes the blood pump flow rate, that is kept constant around 5 to 7 ml per kg per minute. Dialysate flow rate is 1.5 to 2 times of the blood flow rate. Then ultrafiltration volume. They should also, ultrafiltration volume should be maximum of 5% of total body weight during one session, during that specific session. And conventionally, we are using a 4 hours dialytic session and thrice weekly. This is the conventional or the recommendation from the guidelines. We are still using a 4 hours dialysis per session and thrice weekly. So coming to dose, frequency, duration, and adequacy of the dialysis, the patients with end-stage renal failure should receive thrice weekly dialysis, and that should result in a urea reduction ratio of more than 65%. So urea reduction ratio is calculated by urea at the beginning of the dialysis, and that should be divided by the urea at the end of the. So suppose if the urea level is at the beginning of dialysis is 100 and at the end of the dialysis is 30, then urea reduction ratio is 70%. And that other important aspect for the checking the adequacy of dialysis, we frequently use KT upon V. So KT upon V is a dimensionless ratio, and that represents the total blood volume or plasma volume of the patient cleared of urea during dialysis and divided by the total blood total body water of the patient. And there is a guideline that we will be coming in the next slide about the recommended KT upon V for maintaining the adequacy of the dialysis. So it's not only KT upon V that checks the adequacy of the dialysis. Apart from this maintenance of KT upon V, we also need to assess the patients clinically for the general well-being, the fluid status of the patient, blood pressure control, and the control of laboratory parameters like hemoglobin, phosphorus, potassium. all these things need to be keep in mind while we check for the adequacy of the hemodialysis. So according to K2Key hemodialysis adequacy guideline, which was updated in 2015, there was a recommendation that target single pool KT upon V of 1.5 per hemodialysis session for patients treated thrice weekly with a minimum delivered single pool KT upon V of 1.2. So this is the standard guideline. Though studies have shown that if you maintain KT upon V beyond 1.4 or 1.6, 1.7, that doesn't help in very much. So minimum should be kept in mind. It should be 1.2 to 1.4. Beyond that, it will not be very much helpful. So now coming to the very important part, how to monitor delivered dose of dialysis. So definitely we are setting up or doing a setting in the machine that this KT upon V should be 1.2, 1.4 or 1.6. So does the patient or is the patient really getting that dialysis dose? That we need to check. So for that, on a monthly basis, we can check pre-dialysis and post-dialysis blood urea level and calculate the urea reduction ratio. So from this graph, you can see that if the urea reduction ratio is 0.75, that means at the beginning of dialysis, if urea is 100 and at the end of dialysis is 25, that means the urea reduction ratio is 75. So, and next thing that we need to calculate is ultrafiltration volume by weight, because if the patient is also getting ultrafiltration, there is also ultrafiltration in your prescription order. So definitely the KT upon V will be higher than the patient who is not receiving any ultrafiltration. So by this graph, you can see this on this horizontal axis. This is the KT upon V. On the left side, this is the urea reduction ratio, and on the right side of the graph, this is ultrafiltration by weight. So if the ultrafiltration and weight ratio is 0.6, so if there is no ultrafiltration, if we follow this curve, 0, if there is no ultrafiltration with 75% reduction urea reduction ratio, the KT upon V is 1.5. But if there is a ultrafiltration component in the dialysis also, the ratio of ultrafiltration and weight is 0.06. And if we follow this curve, then approximate KT upon V comes around 1.7. So with ultrafiltration, there is an increase in KT upon V. If we go back to our physiologic principle of dialysis, if you remember that with ultrafiltration, there is a solvent drag. That means with movement of water, there is also movement of small molecules that comes along with the fluid movement across the membrane. So if there is ultrafiltration, there is a more effective clearance of the urea is more in comparison to patients who are not receiving any ultrafiltration. So while calculating KT upon V or adequacy of the dialysis, we need to keep in mind this graph, and by that we can have an accurate reading of approximate KT upon V of that patient. Now coming to the monitoring aspect, how to monitor the patients who are on maintenance hemodialysis. There is one clinical parameter and the other is a laboratory parameter. So the clinical parameters are prior to dialysis. How will we evaluate on daily basis, or not on daily basis, but whenever the patient is coming for dialysis? So normally we take the pre-dialysis weight and we compare with the last post-dialysis weight and dry weight. For dry weight, I will be coming on the next slide. So we see by checking the weight at the start of dialysis, we check how much weight the patient has gained weight during interdialytic period. That is also called interdialytic weight gain. Then blood pressure. If the patient is persistently having pre-dialysis hypertension, that mainly indicates that there is a more fluid overload, and patient and we need to recalculate the dry weight of the patient. Even the hypertension cannot be related to increased weight gain when it's can be due to renin mediated. We need to check the temperature of the patient to see if the patient is having infection related to the vascular access. Also need to check the vascular access site to see the exit site infection. And during dialysis, we need to monitor patients for every 30 to 60 minutes for blood pressure and pulse rate. Now coming to the laboratory part, the blood urea and creatinine should be checked on the monthly basis. Potassium, calcium, and phosphorus also on the monthly basis. Bicarbonate, then hemoglobin, albumin we can check every 3 monthly. That will give you an idea about the nutritional status of the patient. The studies have shown that the patient having low hemoglobin has high risk of mortality. And ALP, the ferritin transferrin saturation, and TIBC every 3 monthly. In PTS, we should try to maintain PTS more than 2 times the upper limit and should be done every 3 monthly. And then also the viral markers for hepatitis B, C, and HIV every 6 monthly to see whether the patient has acquired any infection or not. Now coming to the concept of dry weight, this is a post-dialytic weight at which all or most excess body fluid has been removed. And commonly it's determined on a trial and error basis. And we should make a habit of checking of dry weight more frequently. We can check it off every 2 weeks, especially in children, because the children are growing, and if we don't check dry weight frequently, that we can either give a low target weight, which may result in hypovolemia and faster loss of residual renal function, or if it's too high, where if the target weight is too high, the patient might present with volume overload. In true sense, the volume status or dry weight or should be checked by bioimpedance devices in inferior vena cava diameter by ultrasound, lung ultrasound, or intradialytic hematocrit monitor. And these devices are not easily available, not always available. So we normally check it on a clinical basis, taking the patient's blood pressure, presence of edema, tolerance of ultrafiltration, and so we should remember this. So if we see, we should try to maintain euvolemia. So if there is a hypovolemia or hypervolemia on the either side, there is an increased risk of death. So if there is a hypovolemia, the patients will have hypotension or end organ ischemia, leading to faster loss of residual kidney function. Or if there is a hypervolemia, there will be risk of hypertension, edema, dyspnea, or cardiac remodeling, or may result in heart failure. So that's all about my presentation. Thank you. So we can have questions. Okay.
Thank you, sir. That was very informative. We'll take questions for this session subsequently, but currently we break for inauguration. And for inauguration, I call upon stage Professor Arvind Bakka, sir, Department of Pediatrics, Head of Department, and Professor R.N. Srivastava, currently consultant at Indraprastha Apollo Hospital, pioneer of pediatric nephrology, not only for the country, also for the institute. And I call them both on stage for inauguration. I also call Dr. Aditya Sinha ma'am to welcome sir. Thank you, sir. I'd like to invite you to introduce Mr. Rajan Srivastava, sir.
Thank you, Sukanya. Thank you all participants for being today morning here for this meeting. I'd like to welcome Professor Srivastava, who's been our teacher, a mentor for a lot of us over the last so many decades. And it's really great to have you here, sir. I know sir has to leave soon, and that's one of the reasons, you're trying to push this, and we'll probably have the questions at the end, So I think Dr. Srivastava has already as chief of this division at the All India Institute, he kind of enabled growth of not only pediatric nephrology at the institute, but across the country, and not even across the country, in the whole Asian region. So a lot of what you're seeing today in Delhi and around the country, one does owe to him. So thank you very much, sir, for being again being here. So pediatric hemodialysis began at the institute almost. I was just thinking when we were sitting there, almost in 89, 90. So almost 3 decades back. More than 3 decades back. But it has taken us almost another 3 decades to do our first focused workshop, and I'd like to thank Aditi and my fellows and the nursing staff, for getting this act together. I think it's an important meeting. We have had meetings on acute kidney injury in the past, where dialysis has been discussed, chiefly by Vedanta. But I think it's an important meeting to be able to discuss maintenance hemodialysis. And it's the first time we are doing a full day's meeting trying to focus on this. And again, thanks a lot to all the faculty, Professor Manthan, Manish, see Shobha also here. I'm sure others will be joining. The entire Fresenius team who agreed to be here, for this meeting. With passing years, obviously you've seen that peritoneal dialysis has been replaced in many ways, even in children, by hemodialysis, particularly for the older children. So it's a meeting, that wherein we would try to learn the basics. But again, I would like to caution all the speakers and the presenters and Aditi also, try to ensure that there is enough discussion, because at times, because unless we have discussion, this would not we would not be able to do as well. The focus was on nursing colleagues and dialysis technicians wherever there are. So I think this meeting is for you. So please try to get the best out of it. This is not a high-flown meeting, where we are discussing research aspects on dialysis. So the focus is on nursing colleagues and the focus is on fellows. So these are two focus groups, that we would like to reach out today. So please try to do that. I will tell you that Aditi did tell me that you'll be getting all the slides in PDF format at the end of the talks, end of today. So you don't need to take any pictures. You would still be getting access to all these slides at the end. And you're most welcome to give us your feedback on the way the meeting happens. And I'm sure, in a couple of years, we can again do a meeting to supplement this meeting. Thank you, Kanav. As well, there are multiple units in the city that are currently providing hemodialysis, and we would really, I think Delhi has become one of the important places for pediatric kidney care over the years. Finally, I'd like to thank all the people who have supported us in this endeavor. Fresenius, obviously, we've got a number of faculty members from there. You will be speaking. Wokhart did support the meeting, as did Concord Biotech. So I'd like to thank them as well. Mr. Barik, as well as Mr. Sharma, from the set facility. Thank you very much for helping us in this meeting. I'll close here, and I'd like to invite Dr. Srivastava to give us his opening comments or inaugural comments.
Thank you, Survivor. Thank you very much. Delighted to be here this morning for this workshop. We know that hemodialysis in children is more difficult, it's more complex, as Manish has mentioned. We started here about 30 years back, and the first machine was a donation. But it does take a teamwork. And for those of you who are from small hospitals, the dilemma is whether to get the team first or start first. I think we have to make a beginning somewhere. And at many centers, we found that the pediatric nephrologists, they try to work with the adult counterparts to learn the basics of it and get into the hand, unless you have this, and you have to show this, that look, this can be done in children, it's useful, and then perhaps ask for the details. It will be very difficult to have a team in place and then start something. At the same time, we know that peritoneal dialysis is no longer all sufficient in every case. We need new techniques, we need new methods to apply, we need new expertise. This we have to learn. There's no shortcut to it. It takes time. We have to learn ourselves and teach this staff, the dialysis staff and nursing staff and so on, Once upon a time, we used to have during dialysis, we used to have a residents sit by the patient and monitor. Those that's no longer sufficient. We have to have a team, and for maintenance, that Dr. Manish was saying, you need a a follow-up kind of a thing. It has to monitor the child uh, periodically and see. If you look at many other factors, and eventually there has to be a transplant at the end of it. You cannot do it indefinitely. The acute dialysis has been defined. You mentioned about the access and complication, the problems, but over a long term, it is probably not sustainable. I think you have to be a transplant at the end of it. I hope that I see many young people here, uh, perhaps from the smaller hospitals or medical schools, but you have to be in touch with these centers here. You have to come periodically and actually get the experience, just hand-on experience. There are many centers here. They can offer expert methods and train them. And you have to come and just be here and just learn all that. There are no shortcuts to it. I again thank you very much for asking me to come here. It's really a pleasure to be here. Uh, thank you all very much, and all the best to you.
Our first machine, was indeed a donation. It came from UK. So I would remember, when we had a plate, saying that donated by so much so and so from UK. So it began like that. So obviously now, these things are available. Uh, yeah, it's been a long journey. Thank you. Sir. So, thank you. So we'll close the inauguration and we'll continue with the session. It's gonna you can take.
So I call upon him, Dr. Kannavanan, consultant pediatric nephrologist, Division of Pediatric Nephrology and Renal Transplantation at the Institute of Child and Sarkapara Hospital, to continue the session and take on the questions from the previous talk.
Continue the questions.
We'll finish with the session and then we'll take the questions in the end. Next, we have the session on complications during hemodialysis, and it will be presented by Dr. Mahesh V, who is a DM Pediatric Nephrology Fellow at AIMS, final year student. He has also done his MD Pediatrics from AIMS. So I call upon Dr. Mahesh.
Thank you, sir, for the introduction. Thank you, sir, for the introduction. Today, I'll be speaking on the common complications during the dialysis, which mostly the nursing staff would be coming across along with the physician who will be posted there. So this would be a interactive session rather. So I would request our nursing staff to keep asking questions as well as any doubts in between. And in turn, I will also be asking some of the questions. So we can go ahead. So I will be covering the common complications like interdialytic hypotension, disequilibrium syndrome, dialyzer reactions, which are rare nowadays, but still we would be covering it. And I would be covering some of the complications which are not so acute, but still which are very important, like the catheter-related bloodstream infections, because as Dr. Manish was saying previously, we are still using central venous catheters for dialysis in pediatric patients. And we will also be speaking on discussing about the central venous catheter dysfunction as well. So what are the acute complications which you come across during dialysis? So most common is hypotension. So for that, you should be connecting the patient to the continuous monitoring. It depends whether how frequently you should be monitoring the patient. Maybe every 5 minutes, every 30 minutes, or every hour, depending upon individual patient. So it's a most common complication which we come across during the dialysis. And the cramps, the next second most common complication. Can any one of you tell why those cramps occur? Any nursing staff? Because we would be commonly saying that the child would be saying पैर में बहुत दर्द हो रहा है, and he'll be holding on to the cuff and he'll be crying. So can anyone tell? Yeah. So one of the important causes is extra fluid removal along with hypotension as well. We would be treating it with either we'll be saying for giving the fluid, or we'll be checking the monitor that whether hypotension has happened or not. So the other most common thing is nausea and vomiting, which accounts for almost 5 to 15%. So in this thing, rather I can say that the dialysis patients are more prone for nausea and vomiting, even with a minimal upper respiratory tract infection. So the cause is mostly the acute hypotension during the dialysis due to excess fluid removal, as one of you said. The second most complication is headache, which accounts for around 5%. So not many children, maybe the adolescents would be complaining of headache rather more commonly, and the smaller children would be rather crying. One of the important causes is hypotension, but in adolescents, you should make note that if they are repeated coffee drinkers, especially, I don't think so any adolescents will be drinking excessive coffee, where they'll be taking a lot of caffeine. So during the dialysis, as soon as you start the dialysis, a lot of caffeine would be removed. That would cause rebound headache. So few of them in the West, they would recommend giving a cup of coffee during the dialysis if that's the case. So the next most common is chest pain along with back pain. Chest pain and back pain are rather uncommon, but you should be thinking of hypotension again in this case. But if the chest pain is very severe, associated with cough as well as fast breathing, you should be thinking of more dangerous complications like air embolism. Itching, rather less common, around 1 to 5%. Here, you should be aware that itching can happen otherwise also in normal children who are on dialysis, but you should also be taking care of adequacy of dialysis. If the urea is high, it's bound to precipitate the pruritus, and the child will be itching all the time. Rather, I can say the fever and chills are very less common. If the fever and chills are there, then you should be thinking of either the reactions or any pyrogenic reaction secondary to the catheter-related bloodstream infections. Coming to the interdialytic hypotension, there are various definitions, but most of the nursing staff here would be knowing that once the systolic BP is around 90 or less than 90, we would be worried. And we would be checking on the heart rate as well. There would be associated tachycardia, and the child would complain of lightheadedness. Even the child would be sweating sometimes. So you check the BPs, and if the definition wise, the Kidoki says that the decrease in systolic blood pressure more than or equal to 20 millimeter of mercury from the baseline prior to the start of the dialysis session, you would be measuring the BPs, and if it is falling more than 20, so you would be worried. And there are various other definitions like European best practice guidelines says the same. Either you take into account either SBP or MAP. Japanese guidelines says much bit higher, like 30 millimeter of mercury. The best thing, or the most frequently used thing, is this Nadir 19, where you would be worried when the systolic BP falls below 90 millimeter of mercury, where you would be acting. So these are the definitions widely used across the world. So what are the risk factors for hypotension? So you know that most of the dialysis technicians would be worried about the interdialytic weight gains. So when somebody has an interdialytic weight gain, for example, maybe 1.5 kg or 2 kg, you would be worried, and you would be enthusiastically thinking that you would be removing a lot of fluid from that. So the issue with that is if there is a lot of interdialytic weight gain and the BPs are not so high, but it's most of the time the BPs would be high, and you try to aggressively remove the ultrafiltrate, which would cause hypotension again. And if the child has a myocardial dysfunction per se from the beginning, so that would also cause hypotension more frequently rather. And the other thing is most of the children would be on antihypertensives because they have a chronic kidney disease, and we would ask them not to take antihypertensives in the morning. But the issue is it's not universally applied. Universally, it cannot be applied universally because some children would have a higher BPs, would require antihypertensives. Even after giving antihypertensives, the BP would be high. But usually we would tell them to try to avoid the antihypertensives at the morning before or the noon before the dialysis session. Very few children would have hypertension associated with the food intake during the dialysis because due to food intake, there will be increased blood supply to the gut, which would cause cooling of the blood there rather in the intravascular compartment where you would be connected to the, there the child would be connected to the extracorporeal circuit. So better avoid food during dialysis. It's not the case in every child, but if one of the child or one of the case is more prone to that, better try to avoid. And you should be checking anemia for hemoglobin, as sir was saying in the previous talk. We should be checking and you should be correcting. The children who have anemia would have a higher incidence of hypotension. As I said, if there is large interdialytic weight gain, you would tend to set a higher ultrafiltrate, so that would cause hypotension again. There are studies which say that if you are using low dialysate sodium, say 125, 130, or low calcium, say 1.25 millimole per liter, those settings are also associated with hypotension during dialysis. The buffers like citrate buffer, acetate buffer, which is not used currently, are also associated with increased incidence of hypotension. So how would you prevent hypotension during dialysis? The first line would be reassessing again and again the target weight rather than you target a dry weight. It's not sacrosanct to tell that exactly this is the exact weight of the child. It is based upon trial and error methods. You would be frequently monitoring the weights. The child may gain weight or may not gain weight. Accordingly, you should be targeting a weight in the child who is on dialysis. I said avoid food during dialysis. It's at the discretion of the physician and the nursing staff who would be seeing the child frequently. So you should decide upon whether to give antihypertensives before a dialysis session or not. And we would ask the children and the parents to decrease excessive intake of sodium between the dialysis sessions. And if somebody has a good urine output, say some cases of non-glomerular diseases of the kidney would have preserved outputs. So there, if there is a presence of residual renal function, you would better increase the urine output by giving maybe furosemide to some of the kids. That would increase the urine output and also decrease the interdialytic weight gain, which is responsible indirectly for hypotension. The second line would be during the dialysis session, you would cool the dialysate, but it should not be very aggressive. Try to decrease by 0.5, which would cause constriction of the vessels, basically. So the constriction of the vessels would increase the blood pressure. So it should not be very aggressive. It should not be more than 1 or so, but you should be seeing what's the tolerability level. One thing is tolerability level is key. You would be checking upon whether the child is developing chills or not, and as well as you will be checking for the BPs. It should not be very high BP records as well. So I'll be discussing in detail about sodium profiling and ultrafiltrate profiling as well as blood volume monitoring in the upcoming slides. The third line would be using pharmacological agents. Although we rarely use these drugs mostly, but in the adults, they have been using frequently for somebody who is prone for hypotension during the dialysis session, basically midodrine, which is available in India as 2.5 as well as 5 mg tablets. Mostly the dose would be like giving 10 mg of midodrine 15 to 20 minutes before the dialysis session, which would prevent the hypotension during dialysis. And there are case series as well as case reports of using sertraline as well as vasopressin during the dialysis who are more prone, the patients who are more prone for hypotension. So what is sodium profiling? The machines which we have in our unit have both sodium profiling as well as UF profiling. The 4008S as well as 5008S machines have the sodium profiling with varied graphs. So as shown in this figure, we have a linear one where you would be using a higher level of sodium initially, like say 145 to 150, not more than that, and you would be dropping through the dialysis session. So what happens is if you are increasing a dialysate sodium and your blood sodium is lesser, the sodium would just shift into our blood compartment. That would increase the osmolality of the blood, which would get in the fluid which is in the extravascular space into the intravascular space, which can be removed as ultrafiltrate. So and if the intravascular volume is increased, as I said, there'll be automatically there'll be increase in your PP. So but the issue with this sodium profiling is you have the child would complain of increased thirst because you have increased the tonicity of your blood because of increased serum sodium levels, and there'll be increased interdialytic weight gain because the child has thirst. He or she would drink more water and the interdialytic weight gain would increase. And it's also said that if it is like a lot of sodium in the blood, it will again cause hypertension. But you have benefits in this. So there'll be decreased interdialytic hypotension, better ultrafiltrate removal, and less usage of saline boluses for hypotension. But the thing is, it has disadvantages, which is more of an issue. So the target or the aim is to achieve a neutral sodium balance along with the prevention of hypertension. So the studies as well as a lot of meta-analysis have said that stepwise sodium, which is sodium profiling, which is shown in the second graph, is a better thing for if you're profiling a sodium. So along with that, if you're clubbed with ultrafiltrate profiling along with sodium profiling, it would be have maximum. It will fetch us the maximum benefits. The other thing is the ultrafiltrate profiling, where you would be removing a lot of fluid initially, and you will be decreasing the ultrafiltrate rate through the dialysis session. But the issue is if you are very aggressive at the initial part, that would cause hypotension suddenly. So you should be using different graphs. And the studies have shown that stepwise profiling is associated with IDH. Rather, if you're using the ultrafiltrate profiling, you use linear profiling, which is better to reduce interdialytic hypotension. Currently, most of the machines are advanced machines have sodium as well as ultrafiltrate profiling in a clubbed way, along with online monitoring of sodium, which comes in the name of natrium, where it will be measuring the sodium which is present in the blood. Accordingly, you can adjust or increase or decrease the sodium levels in the dialysate so that the maximum benefit would be there for the child. For example, the sodium should be at the end of the dialysis, the sodium should be neutral. It should not be excessive, it should not be less. So that's our intent doing sodium and ultrafiltrate profiling, but advanced machines have those things. Coming to the blood volume monitor, this is a extra piece of tube which would be connecting to the venous line, where you will be measuring the hematocrit inside the that tubing. So here, as shown in this figure, you can see that tubing, there will be a light emitter at varied wavelengths, which would emit from one side and it will be received on the other side. Based upon that, the hematocrit will be calculated based upon complex algorithms. So it will give a amount of hematocrit. Inversely, you can calculate the blood volume present in the body. So there are various profiles of blood volume monitoring, as shown in the figure. Profile A, if at the end of when you set up the blood volume monitor, and at the end of 1 hour, if you see that there is a profile A which is shown in this figure, it is almost a straight line. Here you can see that if this is the graph, you could infer that the blood volume loss or change per hour is less than 3%, and there is a scope for increasing ultrafiltrate. It's a profile B where there is linear decreasing in the graph. it means that there is a blood volume change of 3 to 8% per hour, and you need not do anything. This is the ideal setup which we would like to have. And the profile C is the excessive removal in the initial hour, which is more than 8%, which would cause hypotension. So at that particular point of time, if you see a profile C a graph, you should be decreasing the UF or maybe stopping, because that would cause hypotension in the child along with the symptoms. The other issue is, the other thing is, along with the blood volume monitor, the latest machines also have a feedback loop as well. So which would here you are doing it manually, but there are feedback loops where the machine would be automatically adjusting the UF rate according to the profiles. So the advanced machines all have all this thing. Coming to the next complication, which is rarely seen nowadays, but still because of the awareness of the dialysis disequilibrium syndrome. So what are the risk factors for dialysis disequilibrium syndrome? First, hemodialysis. If you are very aggressive in the first hemodialysis session, for example, you are using a higher blood flow rates, you are removing an excessive ultrafiltrate, or you are using a bigger size tubes as against the size of the child. These all would cause dialysis disequilibrium. So what's the mechanism of dialysis disequilibrium syndrome? Here you can see in the picture, the green thing is the urea and the blue round thing is the water. This is a brain cell. So what happens is, here you can see that the urea is almost of the similar concentration in the inside as well as outside the cell, just prior to the dialysis. So what happens if you aggressively remove this urea, the initial part of the dialysis, what happens is the urea is excessively removed. You know that the urea is a smaller molecule, it can pass across the membranes very easily. So that would cause excessive removal of urea as against the urea which is inside the cells. So as I said, that it is easily movable across the cell membrane, but what happens is in this, to come back to the intravascular compartment, it would at least take 4 to 5 hours. So in this scenario, what happens is, because the tonicity inside the cell is more, the water outside is more. So what happens is the water would seep into the brain cell and cause cerebral edema, which would lead to nausea, vomiting, restlessness, headache, and in severe cases, you can have seizures, obtundation, as well as coma. So if it is dialysis disequilibrium syndrome, then you should be treating it. How do you prevent the dialysis disequilibrium syndrome? As I said, you should be not more aggressive in the initial session of dialysis. Keep a lesser blood flow rate, keep a lower UF, as well as you can use sodium profiling in that case, because as I said, you need osmoles basically in the intravascular volume. You can increase the sodium if that's the case, because if you need a longer dialysis session due to some reason, maybe hyperkalemia, maybe you need to remove fluid because the child has a fluid overload. So you can do a sodium profiling. Otherwise, you can use even IV mannitol as also at 1 gram per kg. Because everything is inside the machine, you can do a sodium profiling, which would prevent the osmotic disequilibrium. Treatment would be, as I said, you can use a quick sodium modeling soon after the onset of the symptoms, or you can give a hypertonic saline or mannitol, and you should be stopping the dialysis and treating the symptoms. But in adults, what they do is they rather initially do quick sodium modeling or give IV mannitol initially. But it's not the case in children. You might be stopping the dialysis at that point of time, and you might have to continue daily dialysis for a shorter session, and which are of less efficiency. So the other thing was the allergic reactions. The allergic reactions can happen due to two things. One, the medications. The heparin, like the heparin itself, would cause a reaction. Otherwise, the other things, like when you're using blood products, that would cause a reaction. Even IV iron, which you give at the end of the session in chronic hemodialysis weekly, that would also cause hypersensitivity reaction. If you come to the dialysis per se, the dialyzer membrane would also cause a reaction. Maybe it might be first use reaction, or it may be in the subsequent sessions where you are reusing it. So that would also cause dialyzer reactions. Although I was discussing with our nursing staff yesterday, they said they have hardly seen any reaction with the dialysis membrane. So there are two types of reaction in the dialyzer membrane, type A and type B. Type A is more severe and type B is not so severe. type A is mediated by Ig mechanism, and type B is mediated by complement pathway. So if somebody has allergic reactions, you should be also aware of the other types of reaction, like the child would mostly maybe having fever, should be secondary to your bloodstream infection, or might be having air embolism, but it would manifest in a different way. But one of the common symptom is the child would be restless, having tachypnea. So you should also be thinking of the other causes of this particular presentation. So how do you minimize the reactions? You should be priming the dialyzer as well as the tubings before the dialysis. If you are using for the first time, the dialyzer and the tubing should be flushed or rinsed at least with 1 liter of normal saline. If you are reusing it, because you would be storing in the reuse, we are using renin for that. So if you are reusing it, you should be flushing or rinsing it with at least 3 liter, and you should be checking with the strip that the residual renin is not present. And previously, ethylene oxide was used for sterilization of this dialyzers, which is no longer used because of the dialyzer reactions. So switching has happened to gamma as well as steam sterilizer dialyzer, but still they can cause reaction. So it's always better to rinse the dialyzer as well as the tubings. So when you come across a reaction, please stop the dialysis at that particular point of time, and you should not be returning the blood back to the child, because that would have the allergens, which would further increase the reaction. So you should be keeping antihistamines, corticosteroids, and epinephrine handy. So most of our dialysis setups would have the doses as well written in each of your booklets, in the nursing booklets at the start of the book. You will have the doses as well. You will have how to dilute it and how long to give. It's all written in your nursing staff book. So other condition, as I said, you should be ruling out hemolysis, air embolism, as well as pyrogenic reactions. So these were the acute complications. The other important two complications which I would be covering is catheter-related bloodstream infection, as well as catheter dysfunction. Catheter-related bloodstream infection, you'd be suspecting when during the dialysis the child develops fever along with chills, along with the insertion site showing some sort of tenderness, pus discharge, as well as redness. Hemodynamic instability. So this is one of hypotension is could also happen in CRBSI. This is one of the reasons for hypotension you should be keeping in mind. And if it is blocked, then if there is an intraluminal clot, which should be infected as well. And if there is clinical signs abruptly after the catheter, if you are starting the dialysis, and soon after the starting the dialysis, if there are clinical signs like there is fever, chills, and dryness, initially you would be ruling out dialyzer reactions. But although since the dialyzer reactions are less nowadays, you should be thinking of catheter-related bloodstream infections. So laboratory investigations, you should be, if you are removing a catheter, you should be sending a tip culture on a roll plate. If the hemodialysis catheter is retained, blood sample should be taken from the ports. And in case of a exit site infection, you should be taking the swab from the site, and you should be sending for a culture. And because we should be knowing the prevalence of whatever the organism and what is the incidence of CRBSI in each dialysis setup, it is always good to maintain a register so that we can look back at any particular point of time to see the prevalence and the prevalent organisms and the way to treat it. So, how do you go about treating CRBSI? So, you would be giving empirical antibiotic, which we are commonly using vancomycin and ceftazidime at renal modified doses in our center. If it is uncomplicated CRBSI, which is responding to antibiotics, you need not remove the catheter at that particular point of time. If there is no organism has been isolated, you should be continuing the antibiotics for at least 2 to 3 weeks. And if the culture is growing MRSA, you should be treating with vancomycin for at least 4 weeks. And if it's a complicated CRBSI, along with associated hemodynamic instability, as well as hypotension requiring inotropes, so then you should be continuing antibiotics for a longer period of time, and you should be assessing the cultures timely and changing the antibiotics accordingly. So how do you manage the catheter? If it's not a complicated CRBSI, you should be keeping the catheter in situ, and you should be treating with antibiotics based upon the response. If there is no response, then you should be removing the catheter and you should be sending the tip for the culture. If there is issue with the vascular access, because there is only 1 or 2 vascular access left in that particular child, you should try to preserve that catheter unless there is severe sepsis. You should try to preserve it, and you might exchange a catheter over the existing catheter as well. What are the strategies to prevent the CRBSI? This is the most important part, because this is entirely based upon the nursing staff. Because starting from the cleaning of the hub, removing of the lumen, as well as taking out the blood, it's the role of the nursing staff is very important here. At least, yes. So for antibiotic locks, we are using commonly the antibiotic locks, which consists of vancomycin as well as vancomycin along with heparin. We would make a final concentration of 12.5 mg vancomycin along with 2,500 units of heparin in each port. So catheter dysfunction is common because we are using catheters commonly. You should be suspecting it if there is more than 10% decline in the blood flow rate and inadequacy of the dialysis has been noted. So if it is an intrinsic thrombus, you should be using a urokinase lock. You should be leaving it for at least 4 hours, or you can be using it as an infusion. If it's not working, then you have to do a linogram with the help of a contrast, and then you should remove the catheter if there is fibrin sheath. So if it's an extensive thrombus, it has to be managed based upon the anticoagulant therapy. If it's extensive, try to give IV heparin for 5 days and remove after that once the thrombus has stabilized. And you have to continue the anticoagulant therapy for at least 3 months in BD doses maybe. Other uncommon complications are hemolysis, which are mostly secondary to renalin in our setup, or it could be because of the chloramines, which is present in the water supplies. Air embolism, as I said previously, arrhythmias can happen, even cardiac tamponade as well as intracranial bleed. So my take-home messages are the minor complications are very common during dialysis, and everybody should be knowing about this and how to treat it. And the key is the close monitoring and the ability to identify the complication. And interdialytic hypotension prevention is of importance because it has long-term benefits. DDS is although rare nowadays, but one should be cautious about the symptoms. And adequate rinsing of the dialyzer prior to the dialysis is very important, and strict asepsis as well as regular monitoring prevents the catheter site infection, which should be taken care of. Thank you.
Thank you. One thing, I'd like to, as we have gone through a journey of setting up hemodialysis services at the institute, I must again underscore the importance of the nursing personnel. Without them, and just as Dr. Srivastava said, the role of physicians is supervisory, if at all. So really the key are strong nursing personnel. So I think whoever is here, you need to learn these skills. And I think most of you are aware, and here I would like to acknowledge Mr. Anand Tiwari, who has been, in many ways a rock in the last 2.5, maybe 2 decades. And Anand, could you just stand up, for people who don't know you? And he and the entire team, they've really worked, and he's been teaching colleagues across multiple centers. I should have mentioned that during the inauguration, but I think sir had to leave very early, so it got skipped. Thank you very much. Questions? We have time, so please feel free to ask questions, and for both the talks, Manish's talk as well as Manish's talk. And so we were trying to give you an overview, so please feel free to ask questions. So how many of you are finding hypertension as a major problem during dialysis? The nursing personnel बताएं और कहाँ से हैं?
नर्सिंग में कौन-कौन आएगा?
बताओ बेटे. बताओ. Do you find it as a complication? और क्या कारण क्या होता है, जैसे बात कर रहे थे? So rapid fluid removal आप कह रहे हैं, that's probably one reason. और कारण क्या है? Okay, so what about the experience at other centers?
अगर आप बताइए वहाँ पे, I think we are more seeing cases of intradialytic or during hypertension is more commonly we see. Yeah, and I think it's a more problematic hypertension rather than managing hypotension. Yeah, sometimes even requiring इनवास तक ऐसे लगता है, डर लगता है देने में. हाँ, तो हाइपरटेंशन बहुत प्रॉब्लमेटिक है, इसके बारे में कुछ अगर हम कर पाए.
When I read up, it seems to be, it appears to be more of a neurogenic kind of a thing because of the RAS system and all activation.
And
So it was mentioned that even if you small doses of base inhibitors
yeah, it was.
prior to dialysis, it works. So I think we need to
And,
emphasize
and if you are dialyzing the patients regularly, thrice weekly, so I don't think the hyperkalemia will be a problem for these patients.
Yeah.
So I think involves can be used in patients with
this is what we
refractory.
tried and it worked.
One thing I would also like to emphasize here that the patients with increased interdialytic weight gain. So we keep on telling patients that इंडियन की पानी कम पीना है, पानी कम पीना है. हम ये भी कहें कि नमक कम खाना है, सॉल्ट कम देना है, वो बहुत इंपॉर्टेंट है. तो अगर नमक कम देगा, सॉल्ट कम देगा, तो डेफिनेटली पानी का भी इंटेक कम होगा. ये नॉर्मली हम कहीं ना कहीं वो पानी के पीछे पड़े रहते हैं, और ये सारा का सारा जो वेट गेन है वो केवल पानी की वजह से नहीं होता है. वो जो मेटाबॉलिज्म हो रहा है फूड की वजह से, उससे भी वाटर जनरेट होगा, वो भी होगा. तो केवल ऐसा नहीं है कि अगर 2 किलो का वेट गेन है तो पूरा का पूरा 2 लीटर उसने पानी पिया होगा. सॉल्ट रिस्ट्रिक्शन शुड बी एम्फसाइज्ड विद द पेशेंट्स. तो ओवरलोड इसलिए नहीं, वो बहुत हम ज़्यादा एग्रेसिव होते हैं, हम बहुत ज़्यादा एग्रेसिव हो जाते हैं कि ठीक है उसका 3 किलो वजन बढ़ाया तो हम उसको 2.5 किलो निकालते हैं. वो 5% हमने, हाँ, तो कहीं ना कहीं उसमें फिर हम डायलिसिस ड्यूरेशन बढ़ा सकते हैं rather than taking out 2 लीटर in fluid in 3 hours or 4 hours. तो डायलिसिस ड्यूरेशन बढ़ा सकते हैं या फिर फ्रीक्वेंसी बढ़ा दें उसका, rather than डायलिसिंग 3 times a week उसको हम 4 times करें, 5 times करें, फिर टारगेट वेट को हम अचीव करें. तो वो एक तरीका है, उस तरह से हम कर सकते हैं.
फ्रीक्वेंसी बढ़ाना ज़्यादा बेटर है. That is one question, Dr. Manish. Given a choice between diafiltration and hemodialysis as a routine practice,
स्टडीज आर कमिंग अप. हमने डिस्कस किया भी था, छोटा सा ही दिखा था क्योंकि लग रहा था कि ठीक है ज़्यादा हो जाएगा उसमें. तो उससे जो निकल के आ रहा है यही है कि डायफिल्ट्रेशन इज बेटर देन हेमोडायलिसिस. if we are keeping the patients on maintenance hemodialysis for a longer duration, so cardiovascular outcome, growth part, better blood pressure control, phosphorus control, ये सारी चीजें definitely the patients will do better if we keep the patient on hemodiafiltration rather than
majority they are shifting out
hemodiafiltration. So that, I think that's the only study that has come from pediatric side, and that's the observational study. Definitely, we will be needing more randomized trials to see the effects of hemodiafiltration in comparison to hemodialysis. I think that can be done. But again, in pediatrics, normally we dialyze keeping in mind that the child will ultimately get renal transplantation. So long-term outcome will not be that applicable what we see in the adults. So outcome का difference रहेगा.
This is the much lesser comparative. Mostly is also factor time. Almost 3 times more than the.
Definitely. Possibly again water treatment unit. Normally जो हम dialysis कर रहे हैं, हाँ, that you need ultra pure water for hemodiafiltration because you will be using a high flux dialyzer. Large amounts of fluid will be given. You will be giving patients a very large amount of fluid. So definitely cost will be an issue. 508 है आपके पास तो आप कर रहे होंगे hemodiafiltration. अच्छा.
Questions from our because they have also gone virtual, so we have people joining from different centers also. And they're asking you questions. Reaching dry weight clinically, especially in a anemic child, can be challenging. hypotension also occurs and they also have huge thirst, so they have internet.
That will be tough to reach a target weight or dry weight in an anuric child. So in that case, what Mahesh told us in a slide, yeah, profiling or that using a blood volume monitor, that might be helpful. So definitely in those cases, we will need a bioimpedance devices or measuring a IVC diameter or lung ultrasound, all these advanced things that will work. So clinically, it's not always right to uh, find out the target weight clinically, just taking the blood pressure and the fluid aspect. So in those cases, definitely we will need these aspects.
So maybe we just address some of these questions in the afternoon session. That's volume monitoring.
Right.
One more question is about about priming of blood circuit. So in smaller children where extracorporeal volume exceeds 10%, do we need to blood prime in each session and do we need to discard the prime blood?
What normally we do, either we prime with the blood or 5% albumin. So ideally we should discard at the end of the dialysis, otherwise it might lead to the volume overload at the end of the session. So that will be the idea of discarding the at the end of the dialysis.
Add on in case the child is anemic, maybe we can give it and remove that extra fluid during the ultrafiltration.
Yeah,
If the child is not anemic, that's better not to return it back.
Right.
Yeah, because discarding will also
loss. कर सकते हैं. अल्ट्राफिल्ट्रेशन करना पड़ता है. अवेलेबल हैं, इशू नहीं है. क्या अल्ट्राफिल्ट्रेशन में निकाल
ज्यादा करना है तो करना ही पड़ेगा. जरूर अभी जो सर्वे के 5 ml के आसपास 19 ml के आसपास जो प्राइमरी सेल्स नजर आ रहा है.
ट्यूबिंग जो मिल रही है अभी जो उसका जो स्मॉलर जो ट्यूबिंग है, दैट्स 50 ml प्राइमरी वाला जो आ रहा है, उससे छोटा का तो नहीं है ना. न्यूनेट करके तो कुछ नहीं, वही पीडियाट्रिक वाला ही होगा. नहीं नहीं, केवल वो उसकी बात कर रहे हैं ट्यूबिंग की या डायलाइजर प्लस ट्यूबिंग.
तो एफएक्स डाले जा रहा था 0.2 मीटर सरफेस एरिया उसको 90 ml से.
न्यूनेटल पीडियाट्रिक और सारे.
नहीं, मैं पूछ रहा हूँ पीडियाट्रिक न्यूनेटल की है जो हम लोग उसका 50 ml है प्राइमरी वॉल्यूम. लेकिन जो पीडियाट्रिक था जो हमने मंगाया था उसका ही 50 ml ही था, 60 था उसका.
तो टोटल वही 65 ml या 70 ml के आसपास, इससे ज्यादा नहीं. क्या कोई भी बाइक सिर्फ 2 प्लस जाए.
Yes, there were comments from there, yeah.
Yeah, there's a difference of 10 ml of volume. 50. Yeah.
And this pediatric tubing has 90 ml approximate.
Okay.
And adult tubing 125 ml.
150 आता है उसका.
125.
जो एडल्ट जो हम लोग कर रहे हैं वो 150 है उसका. 150 का 140 150 का है. पीडियाट्रिक वाज 50 जो हमने कल देखा था. अच्छा.
Just one more comment. Yeah, please speak. Yeah.
Yes, is it an absolute threshold value which we have to give? And should we give in all children or should we just reduce the length of the session?
So basically, if your urea is more, adult
the threshold is 175 seen in most of the studies. If the urea is more than that, then you should be cutting short the dialysis. Use a smaller tube rather, because in pediatrics, we would be using a pediatric size one, and a smaller dialyzer comparatively according to the body surface area could be tried. But if in some cases you need to do a longer session, then you might prophylactically give IV mannitol at 1 gram per kg.
You hardly need use of mannitol, and by just decreasing the blood flow rate, you can decrease the risk of decreasing the urea. What we discussed in our first presentation, that this clearance depends on three factors: the blood flow rate, dialyzer KOA, and the dialyzer flow rate. So dialyzer flow rate is almost constant at 500, and you can choose your dialyzer based on your requirement of clearance. And the one thing that is in our control is the blood flow rate. So normally we are in habit of fixing at somewhere around 5 to 7 ml per kg per minute. So if you decrease the blood flow rate, that can also decrease the sudden fall of urea. So that will be very useful practically.
If the urea is very high, you can decrease the dialysis flow rate also.
Yeah, that can.
Any other questions from the nursing colleagues who are there? Dialysis technicians, any queries, any questions?
Hi, good morning. That might result in clotting of the circuit. So below 100, it's difficult. Right. Yeah, in a bigger child we can. हाँ उसमें कर सकते हैं.
Yes, sir. We have been using at 50s and 75, it works well. I think it increases your chances of clotting, that will take care of the anticoagulation. Any other questions from anybody? Any queries?
How long we can use this under
Pardon, please repeat.
Sunderland is most usually used for as a vascular access. So how long we can use?
Yeah, if you are using a cuffed venous line, that you can go up to 3 months, 4 months, or 6 months like that. But if you are using this uncuffed catheter, so they say that it should be removed. If you are using in the IJV, that should not be retained beyond 3 weeks. And if you are using in the femoral catheter, that should be removed in 1 week. But many times we are using uncuffed catheter with IJV, and it goes till 3 months, 4 months like that. So that all depends on your. Ideally, you should use cuffed. That's guideline also. So for maintenance hemodialysis, the fistula is the main thing. That if you have a plan that the child will have to keep on maintenance hemodialysis, go for fistula. But if you are not being able to, the child is very small, fistula can't be created, then in those cases a central venous line works. So better to go for a cuffed venous line, that you can keep it for longer duration, more than 3 months. Officially, what? Yeah, if uncuffed catheter, then it should be for 3 weeks. Yeah, मैं ऐसा ही है मुझे लग रहा है 3 weeks ही है. और अगर आप femoral में कर रहे हैं तो 1 हफ्ते में हटाना है. हाँ, लेकिन cuffed को आप रख सकते हैं.
We move on to the next speaker for this symposium. We introduce Amit Agarwal. Amit was with us for a couple of years and before he at Batra Hospital. And many of you are aware about this rather unique initiative, in in which we were given an area to work in the hospital, and by Ramit gets and totally supported by South End Rotary. So everything is supported by South End Rotary, including the equipment, including the costs of dialysis, including the salaries to the nursing and technical staff. So it's been a major philanthropic effort on part of Rotary, and this has enabled a number of children, who would otherwise not have got dialysis support for their end-stage kidney disease, as well as at times for AKI. And Amit has been providing this now for close to how many years now, Amit? 7 years? 10 years? 10 years now, so it's really something major that has happened, and totally philanthropic. There's no patients do not have to pay money. In fact, there are a number of our patients who want to go to his unit, to get dialyzed there, because when they come back to us, then they have to pay. So, Amit, thank you very much, and can you share your experience?
Thank you so much, sir. First of all, for training us, and definitely there's a huge role of Anandji in it for training the nursing staff and training us as well. And there are so many things I have to thank for, including Rotary, AIMS, and especially the Batra Hospital, who is giving us a rent-free space, free electricity, free water, and all those stuff. So I'll just be sharing that how did it started 10 years back and what we have achieved till date and what are the unique features of our center. So this is the logo and this is the service of ourself was the motto which we wanted to go ahead with. I will be talking that how it has been concepted, that how all three institutes, including Batra, Rotary, and AIMS has come together to make this happen. There has to be a sustainability, then the continuous improvement in the practices, then what we have achieved and what we are looking for in the next few years to go about it. So it has been started in 2011 when I joined the fellowship here in 2011 to 13. So it has been started. So they thought that they should Rotary thought that they wanted to do something in the pediatric age group. There was enough funding agencies for cancers, hemophilia, heart diseases, but there's been nothing, absolutely nothing for kidney diseases in kids. So then the head of the Department of Pediatrics, Dr. V.K. Paul, has come to the picture and started, shared his vision to set up a pediatric dialysis center along with Paga sir. And this is how the roles and the responsibilities of the partner has been divided. So each and everyone has to fulfill into the system. So the AIMS was looking into the quality management, oversight, that how the system is running, training of all the staffs, nursing staff, medical staff, paramedical staff, everyone. Rotary has looked after the infrastructure, the equipment, running and operational costs, and Batra has obviously provided us the rent-free space. So these are the visionaries. If I look into it, you can see Dr. Paul sitting left, the extreme left, and Dr. Aditi standing right in the between, and then the Rotarians. So these are the salient features of ISPERSH, the South End ISPERSH we are running. This does not cost anything. We just don't charge a single penny from the patient. They don't have to bring anything. They just walk in, get dialyzed, move out of the system. And this is probably the second after the Chacha Nehru to have an exclusively pediatric dialysis center, which is a 3-bed dialysis center. It is a perfectly child-friendly environment. Child does not feel scared coming into the center. If you walk around the center, you will feel that it's welcoming kind of thing. And we are keeping a nursing staff to the patient ratio is 1:1. So every bed there is one attending person, whether it's nursing staff or a technician. So the major challenges we started with was to select the patient who will get dialyzed at these centers, because there are innumerable patients to which we can offer this service. But as we have already talked in the previous talks, that transplant has to happen in the kids. Kids cannot go on and on maintenance hemodialysis. So the inclusion criteria at the dialysis center we have chosen is that kids has to have a transplant in future. maybe preferably in 3 months, then sometimes 6 months, maybe a year later, because some diseases requires a waiting period before the transplant, like SLE or nephrotic syndrome kind of things. Then finding a trained personal pediatric dialysis staff. That was another major hurdle we faced while starting the dialysis centers. So everyone, including me, was trained here. All the nursing staff was trained here before recruiting them. Another, I would say, the most difficult in this is ensuring the uninterrupted supply of pediatric consumables. As we have just now talked about the pediatric tubings, the supply has been really erratic, and we have to manage. Once we take the kids into the system, we have to manage it somehow. So the maintaining and keeping them for a duration, like sometimes we have a kid of 8 kgs, 10 kgs, 12 kgs, and then we don't have these kind of kids for another year. So we cannot keep the supply for this forever because there is a cost involved in it. So making that balance was really difficult. As Dr. Manish has already told, the dialysis access is the main thing. We have only 4 access in pediatric age group. Smaller the kid, more difficult the access is. Then we have made the zero infection policies. We don't give CRBSI treatment, I would say, in spite of having a negative culture, more than 2 patients, 2 courses of antibiotic therapy of 14 days in a year. So if we take 100 dialysis per month in 1200 dialysis, only 2 courses of antibiotic therapy. This means only 28 days. We are only single patient. 1 or 2 patients will get suspicious. Till now, we did not get any CRBSIs proven in our system. And fortunately, patients do not develop symptoms as well. It's not that we are not getting the cultures right. It's the patient does not develop the symptoms. They don't develop fever. If they have a fever, they will. In the last season, we have few dengues, we have malaria, we have COVID, but none of them had a CRBSI. And the preparation for kidney transplant, who will do the kidney transplant? So obviously currently the pediatric kidney transplant is being done only at AIMS. So if we look at the cost analysis, how much it required. So if we look at the initial investment is around 50 lakh rupees to set up a 3 dialysis center with a RO system in place. And if we look at the per month expenditure, it's too high. It's too high. So if we look at the dialysis, per dialysis cost is almost like a 5,500. So which is Rotary is currently bearing. And it's mainly the manpower cost. It's mainly the manpower cost because we are keeping 1:1 ratio. That will eventually be helping in a way that we are not having any infections. We are able to manage complications, whatever they are happening, a much better way, but it does cost a lot. So it needs a really thinking, and sustaining it is a really difficult task, which Rotary is doing wonderfully till now. So if we talk about how many kids we have dialyzed in 10 years, is around 141 and close to 12,000 dialysis sessions. If we look at how many have got the transplant done, is around 26%. 37 kids has been transplanted till date, 3 are in pipeline. 18 AKI have recovered. So the major goal was to support the patients who get a better outcome, either a kidney transplant or AKI recovery. So we are reaching around 40% if we look into both of them, which is still below par, I say, because this is a dedicated system only to those who are willing for a transplant. So the patients are moving out, and few of them being shifted to CAPD, few of them being transferred to the adult care units. Majority are lost to follow. This is a really sad part of having such a wonderful initiative that majority are lost to follow-ups. Few of them died. The died figure includes those few of those who have been lost to follow-up, and they have informed us back that the patient has passed away. and 11 are still on dialysis. 4 of them are at AIMS and 7 are with us as of now because we have transferred them back to the transplant here. So the minimum weight we dialyzed till date is 7.4 kg and in an 18 months old kid. And the maximum weight was a 78 kg. So we have extremes of age, weight. And so the extremes of ages as well, 1.5 year to 19 years. The most common diagnosis was the urinary tract malformations, the birth defects we have, which is CACO. The most common adverse event, as we all talking about here, is hypotension, which is around 30%. We don't see too much of intradialytic hypertension. There are two reasons for it. Because we do not dialyze acute patients, number one. The other is that we try to keep the blood volume, to keep the chest dry as much as we can. So the number of hypotensions are really high, and if we add a nausea and vomiting into it, this will almost be like 60%. So we are aggressively dialyzing them. Basically, we are making sure that they are getting a 4-hour dialysis each session 3 times a week. If the patient skips a dialysis, we just don't take them back. They are not supposed to miss the dialysis, so we are not closing on even on national holidays. Whether it's a Holi, it's a Diwali, the system is working. Only Sunday is closed. If you have to close it down on a Holi, Diwali, then you have to work on Sundays. As simple as that. So whoever I recruit, I always tell them, no holidays. We are giving you 4 Sundays off. 4, that's good enough. You can take one, maybe 1, 2 more, but not that there is a festival around. So you have to work really hard. Dedicated staff is needed. Because as the sir said, it's the staff who runs the dialysis. The doctors is only a supervisor there. So unless the staff is dedicated, you just cannot run a pediatric dialysis center. We are running at AIMS because the team Anand has, and I'm running it because the team I have. So if we look at the continuous improvement in the care, so in the first 5 years of dialysis, the majority was on temporary IJV catheters. Majority. There was hardly 1 or 2 AV fistulas. And the kidney transplant rate was even this one, 21.3%. Out of 89 kids we dialyzed in that period, only 21% has got the kidney transplant done. In the last 4 years, 4.5 years, we have moved either to Permacath, the cuffed catheters, or AV fistula. Majority of them are Permacaths now. We have only 2 kids, 3 I guess, in the last 6 months who were dialyzed on temporary IJV catheters. Most of them are on Permacaths. The KTP rate has gone a little up, but it's still not satisfying. It's around 35-36%. So there is a problem in sustainability. No doubt about it that if you are running a center which of this magnitude and doing 100 dialysis a month, and that's absolutely free of cost and providing 1:1 care, the funds has been the major issues. And COVID did not help in it because we were surviving on the funds from the corporates who shows their corporate social responsibility funds. And since the COVID has arrived, the all funds has gone to the COVID. So we have been a little short of funds for the last few years, but that's all right. That's a part of the journey. Still we are running, still we are working fine, no issues with it. Continuous motivation of the staff, that is the major challenge. Because day in and day out, they have to work without a holiday, without a long holiday especially. No staff get a week off, never. Never. One staff has to go for a marriage, they got a 10 day off, that's it. They just don't get off. So motivating them to do the service they are doing is a major task. Improving their clinical skills is a major task. Getting into the theoretical aspects of the machines again and again is a major task. The workshops like this would definitely help. So the vision basically we are having is increasing the number of beneficiaries, decreasing the cost of dialysis. As the number of beneficiaries goes up, the cost of dialysis goes down. As simple as that. But how do we increase the number of beneficiaries? We need to have more transplant centers across the city. The pediatric dialysis centers and who are doing a pediatric transplant centers who are doing a pediatric transplant in underprivileged kids. Then giving the improvement in the nutrition of the patients. This has been the major challenge we are facing, and we are trying to improve in whatever way we can, but we are still not reaching where we should be, not even close to that. So nutrition of the patient, we are dialyzing 3 times, 4 times, 5 times a week, so that the urea does not go up. If we give them a high protein diet, high calorie diet. Somehow there has been a reluctance of having a gastrostomy in India. I have a few kids in my private practice who are on gastrostomy and doing well. They gain almost like a 600, 700 grams a month. But this we have to push. This we have to push. And definitely parents get some moral support. They feel depressed. They feel left out by the society. There have been days when I just keep talking to the parents, sitting them for an hour. Then I get to know what's going on into their system. I have seen broken marriages. I have seen child has been left out. So all these things do happen. So the moral and social supports are needed in the chronic care of the kids. This is not a disease which can be cured by something like cured by kidney transplant. The kidney transplant care has to go on, and kidney transplant has its life. That also we need to understand. So the hurdles are the low acceptance by the parents for continuing RRT. RRT includes both transplant and the dialysis. If I go back and look into my data, that who are the parents who did not wish to continue dialysis are equally, even the more the number who got transplanted, And definitely there has been problem with the availability of organ donors. Once the parents are out, there are actually no donors. Whether it's due to the blood group or diabetes or hypertension, whatever it is. Once the parents are out, we just don't have any donor. The other hurdle is the post-transplant expenditure. The transplant expenditure can be covered by various schemes, but what about the post-transplant expenditure? First, the continuing immunosuppression is costly. Then once the child gets ill, the investigations cost a lot. Even in the government setup, they cost a lot because we have to do multiple tests, multiple rare tests. And apart from that, the kidney transplant has its own lifespan, like 15, 20, and whatever years. And if we look at the second most common cause of CKD, ESRD in our group is a nephrotic syndrome. And the nephrotic syndrome has a high recurrence risk. So the kidney may not last 15 years in those kids. So these are the issues which we are facing. That is why we are not able to expand this center, because we are just not motivating as enough ESRD patients to opt for RRT, even after providing a free dialysis. They just move on. So I would say that we have started coming together was the beginning for us, and keeping together is the progress. And working together, including AIMS, Rotary, Batra, will make us succeed one day in achieving more transplants, more AKI recoveries. We expect that every 60-65% AKI or a AKI recovery or a transplant to have a more meaningful version of this project. Thank you.
Thank you, Amit, for a very important talk, and highlighting the unique challenge challenges that children face and their physicians face in providing these services. Uh, it's a uphill challenge, it's a very tough work, and it's only thanks to people like you, and your team who have been able to work. But obviously there's going to be a burnout at some stage. If you don't, yeah, and I'm sure you're seeing that as well. And I think it's happened because there was a lot of support from Rotary. But things like this, for them to get sustained. But do you think there's any possibility of expanding this on a much so that your costs come down and Rotary doesn't feel as challenged?
For that, we need to have a much more transplant candidates. That's the issue. Currently, we are transplanting only 1/3, 30-35% patients. So if we are having a more patients who are willing to get transplanted,
you also have an issue of you just have 3 beds, so you probably can do only perhaps 6 dialysis a day. You can't do more than 6.
Yeah.
And if you take out 4 or 5 holidays a month, so that you're left with something like 150 dialysis a month.
yeah, at max we have reached I think 142 or 144, yeah, something like that, yeah.
So do you think that you require more patients or something, that
Yeah, more patients, sustaining more patients.
but then with a very clear plan in mind.
Yeah.
So I think there's a challenge, particularly for Shobha and Mukta, who share the same clientele as ours in the institute. That if you have patients, who are willing for a long-term plan for children who are
Government would be funding the post-transplant, investigations as well as immunosuppression. I don't know, like whether we'll be able to kind of, have that kind of.
Absolutely.
But on the other hand, sir, like whatever the duration may be, especially when I saw the things during pandemic and all, we need to make it open. We need to focus on the areas where, like the RPGNs, the AKIs, who are
Yes,
going
uncle.
to and maybe you can give them 3 to 6 months of balance.
Yeah.
Another observation, why do you want to keep your patient to nursing staff as 1:1?
ये टेम्पलेट
Opposite
बच्चे के
side,
लिए
there was a
मेरे को
huge
बहुत
number
दर्द
of
था
patients. We were monitoring them with
दांत में
gadgets,
पिछले
with lot of virtual consultation and all. We realized that with the same advice, we can actually kind of see many more patients.
ये तो मैं ये टेबलेट रोज ना लेना चाहता हूँ डेली लूँ के नहीं
मैं भी देख के बता अभी देख के बताता हूँ पूछ के ना
क्या
अभी बता देता हूँ अभी बता देता हूँ
क्रीमलेक्स है ये तो अपने उसकी
पेट साफ के लिए
Problem is that we have a 3-bed dialysis center.
पेट साफ के लिए
If we
हाँ तो
do
ये तो ले लो डोली ये तो ले
personnel
लो इसके लिए
in
पूछ के
one
बता
shift
देता हूँ मैं ना
ये आप
and
देखना
somebody
लें
takes
के
a
लिए
leave,
हाँ ये देख
मैं बहुत दर्द
then we
होता
are
है तो
left
फिर
with
अभी कोई
2.
दूसरी गोली ली हुई है
And then
एक
one
साथ
goes to make the dialysis
बस
solution for the next shift.
कमजोरी महसूस करता हूँ
Only one is left.
एक वो चढ़ाऊंगा
हाँ
So that is another problem. I know.
एक आंख मेरी करीब करीब कम हो गई
अच्छा दिखाया क्या आपने
Yeah, I know.
दिखाया क्या आपने
Going to monitoring and having more monitors and more touch techniques, you can actually
थोड़ी सी
also serve the same purpose.
डिप्रेशन सा
I agree.
महसूस कर रहा हूँ
And
मेरे
Amit,
दो
for
तीन दोस्त
bringing out
भी
the
गए
other hurdles
है
other than the cost factor that
हम
comes in
डायलिसिस वाला
किडनी वाले
being in a private setup. We
कोई
think
बात नहीं
cost is a
टेंशन
big
मत लाया
hurdle.
करो
More than that, the other things.
Yeah. The cost can be taken care of by some way or the other. There would be people like Rotary people or
कंट्रोल तो है
Pradhan Mantri Yojana, we
फिर
can
भी
take up
वो बाबूलाल जी
cost.
चले गए
What about motivating the parents?
कौन सा
That's the most difficult task we face day in and day out. As the ma'am said, that there is a bread and butter issues. So how can they go ahead with the kidney transplant?
Sake of people who are, if you can tell how to refer patients to you so that they can be incorporated into this.
It's very simple, sir. That if they have a long-term plan, they should be transplanted within the next 3 months, preferably at max 6. We don't keep unless there is a disease waiting period beyond 6 months. So we give them good 6 months that you make up your mind, get the transplant.
कल हो गया ना आपको लगाना
If they don't do it, we just move them out.
कितने बजे
So
आओगे? 9?
it's as simple as that. Long-term plan is mandatory because we cannot
Hello.
dialyze each and every ESRT. That's what the problem is.
Or patients with AKI.
Yeah, we can take API, we can take.
Okay.
बाबा के रखो,
हम्म
ये आपके पास ही रखो। और मुझे क्या नाम, ये कितने पैसे देने हैं आप?
The kids who are presently to us and they don't, either they're very poor or they don't have the long-term plans. So is something be done about that? Second thing is, how to increase the disease donor program?
No, we are not running as of now any
8,000
awareness
रुपया,
campaigns in
10,000 रुपये महीने तो किराया में लेना है
public.
तेरे
Basically, it's a public
को।
uh,
ये
awareness which needs to be done to increase the donor pool. We do it one-on-one basis. We do it on one-on-one. As the patient comes, we counsel them for hours, many sessions over a month. That what are the benefits, what are the challenges you wanna face. Tell them pros and cons. Tell them, make them meet. I usually make them meet to the persons who have donated the kidneys. The major issue that what will happen to the father if they donate it. Maybe I have a 50-50 percentage kind of thing where the mother have donated and the father have donated. So currently we are not doing to increase anything in the major because that's the job of, I guess, NOTO per se, to increase the donor pool by strengthening the cadaveric program and making kidneys available more to the younger generations than the older generations, I guess.
Any questions? Otherwise, we can end the session.
Thank you sir, very much.
We conclude session 1. All the speakers will receive the presentation.
Thank you.
Thank you, Baba sir. Thank you, Kanav sir. So we break here for tea and we'll reassemble after 15 minutes at 11:15 a.m. Thank you.
कुलवंत ये वाला स्क्रीन चाहिए मेरे को, या ऐसे क्या है ना, यही रहना चाहिए, यही चाहिए मेरे को। देखो 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 शेयर किया, जस्ट सपोज मैं ये शेयर किया, ठीक है, शेयर करूं, ये देखो, अच्छा ओके, सही कह रहा है। और उसके बाद है जैसे इंडक्टिव को एक्सटेंड कर देते हैं, और ये आ गया, राइट, नहीं ना, यही चाहिए ना, आता है, अच्छा ये स्लो हो रहा है, दैट्स व्हाई, कुछ नहीं, ठीक है, समझ गया। एक अच्छा, हाँ पार्टिसिपेट पीपीटी है क्या, मतलब एक्चुअली कंपनी है वो बेसलाइन में हमारा चाहिए था, तो बताओ कौन सा वाला, नहीं इसमें है क्या, मैं अभी तो इसमें, हाँ दीजिए मैं शेयर कर,
ये हमारा नहीं है, सरकारी है, तो इसमें कुछ नहीं दे सकते। बोल दो ना भी 5 मिनट में वो बात करेंगे, फिर मैं इसको बोलूंगा भी तुम कैसे भी बात तो मना कर ना, 5 बजे के बाद इसको चलेगा। बोलोगे तो वो कैसे करेगा? क्लियरेंस जी, दोनों है, पीडीएफ भी है और पीपीटी भी है। वीडियो कौन है? एक पीपीटी है, एक पीडीएफ है। बाय द वे नहीं खुले सिस्टम में लगे। तो मुझे वो ओपन करना था आपके सिस्टम में, तो 2 स्लाइड हाइड आ रही है, वो अनहाइड करना। ठीक है, देखिए या तो कौन से फोल्डर में मिलेगा। हाँ यही है। ऐसे तो कोई भी नहीं है। हाँ हाँ ये देखिए।
ये डॉक्टर और किसका अभी आपको
मेरा ईमेल ये पेनड्राइव से मेरे कंप्यूटर में तो है
पेन ड्राइव में दे रखा था
नहीं, तो इस पेनड्राइव में डाल दूंगा।
तो आप ईमेल कर दीजिए
कर दूं, ईमेल आईडी बताएंगे।
डॉट सेट
एम
डॉट सेट सर
SCT
हाँ सर SCT डॉट स्टूडियो @gmail.com फिर ये क्या करना पड़ेगा कौन सी है तो ये नहीं है हैं ये भी नहीं भेज रहा कौन भेज रहा है ये डॉक्टर खड़े थे वो तो नाश्ता कर रहे हैं आएगी तो पता चल जाएगी आगे अभी शेयर नहीं हुआ ना
पेनड्राइव लग जाएगी क्या?
हाँ ये तो लगी है
ये मैं निकाल दूं उससे, इसमें डाल के देखूं, निकाल लो।
तो अपने लगा रखा है देखिए सर
अरे वही तो लेके आए
वो यह देख के देखिए क्यों भाई अब तुम जल्दी करो भाई आ जाए
dialysis adequacy, there are lesser infection rate, lesser risk or lesser chances of hospitalization, and also a better
चल रहा है, ठीक है, चलो वो प्रोजेक्शन हो रहा है, उनके लाहौर के लिए और उसके लिए
एम्स डॉट सेट करके ईमेल आईडी उस पर भी कर दिया है। इसमें क्या है ये बोलो ना ठीक है कोई बात नहीं वो नहीं 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 ये मेरा मेल आईडी नहीं है ये इनका एम्स का हाँ हाँ वही बोल रहा हूँ जो ओपन किया ना वो मेरा मेल हाँ जी हाँ जी मुझे ना मैसेज कर दो
Okay, welcome back. So now we have the second session for the day, which is going to be chaired by Dr. Shobha Sharma. She is an associate professor in the Department of Pediatrics at VMMC and Safdarjung Hospital, and Lieutenant Colonel Dr. Subrata Kandra, who is consultant pediatrics and pediatric nephrology, associate professor in the Department of Pediatrics at Army Hospital, RNR, New Delhi.
Morning, all. And I'm Dr. Shobha Sharma, and it is always a pleasure and honor to be coming back to the institute, from whom I have learned whatever the little I know about dialysis and hemodialysis, especially Mr. Anand and his team. So, first session in this will be water treatment in hemodialysis, which will be taken by Mr. Raghuvat Dayal, and he's manager of technical and water solutions. So, Mr. Raghuvat Dayal.
chairperson honorable HOD AIMS Department of Pediatrics Dr. Aditi ma'am. A very good morning to all of you, and thank you so much for giving me this opportunity to come here and to connect with all of you. So I'm Raghu Vardyal, as ma'am introduced me. I'm working as a manager, technical and water solutions at Fresenius Medical Care. So today I'll be speaking on the water treatment systems in the dialysis departments. Why water quality is so important, especially in the dialysis. One of comment from Dr. Manish in his presentation that water quality matters and it does affect the quality of dialysis when we are doing the dialysis treatment. So we'll be learning what is the design of the water treatment system, what are the standards, what are the standards which are regulating the water treatment designing, and the performance and the maintenance of the equipment. At Fresenius, we all on compliance and we conduct business with integrity and honesty in compliance with all laws, company policy, and our values. We are committed to produce products and deliver services that are safe and of the highest quality of our customers. Today, I'll be covering 4 topics in my presentation, whereas the 3 are the topics which I'll be covering, and 4th is we all will be participating together and will be taking questions from you, and I'll try to answer at best. So first topic is the dialysis fluid process. What is dialysis fluid and how it is processed? Then what are the international standards for the dialysis department and for the water treatment equipment? And then the water treatment systems. The first session is dialysis fluid process. Yeah. What is the dialysis fluid? May I hear it from you? What do we understand by dialysis fluid? Please participate. What is the dialysis fluid? Where it is prepared? What does it contain? Why it is prepared? Thank you so much. So, rightly said that it is the mixture of dialysis water, not RO water, it's a dialysis water. The quality of water with which we can do the dialysis, that is the dialysis water, and the dialysis concentrates. What are the dialysis concentrates? Part A and Part B. It get mixed inside the dialysis equipment, that is the dialysis machine, and then a solution is prepared, and it is known as dialysis fluid. So dialysis fluid is required to flow across the semi-permeable membrane, where the dialysis is happening across a semi-permeable membrane. Now, the international standards. We have a lot of standards across the globe, and different bodies are complying different standards. But overall, if we see, there is an international standards ISO, which is being complied or which is being, you can say, derived in other standards also, such as Army standards, the ISN standards in India. So all these are somewhere directly or indirectly derived from the ISO standards. In year 2019, the latest standards which are given for the dialysis are the ISO 23500. And if you see in this graph, the world map, the major color which is dominated is blue color. And these are the countries who are the active members of the ISO, and they are complying and they are bound to follow the standards of ISO in dialysis clinics. So ISO standards for dialysis, as I already mentioned, that in year 2019, the latest version of the ISO standards for dialysis clinics are ISO 23500. If you see in this slide, there are total 5 chapters which are classified in this standard. And chapter 1 is being classified where the responsibility lies with the dialysis clinic operator. And rest of the 4 standards in this responsibility lies with the medical device manufacturer. So if you see the first standard is the general requirements for the preparation and the quality management of fluids for the hemodialysis and the related therapies. Whereas the chapter number 2 is for the designing of the water treatment equipment. Chapter number 3 speaks about the quality of the dialysis water, which is being produced by the water treatment system of a dialysis. Then chapter number 4, it does speaks about the quality of the concentrates for hemodialysis and the related therapies. And chapter number 5, it speaks about the quality of the dialysis fluid. How these chapters or these standards applies in our dialysis clinic. If you see in very first block, ISO 23500-2, it is applicable in the dialysis equipment room and the distribution loop line. The ISO 23500, it is applicable in your dialysis clinic for the water distribution loop and the quality of dialysis water. Then ISO 23500, as it talks about the standards for the concentrates, therefore it is applicable where we are manufacturing or we are preparing our acid concentrates, bicarb concentrates, and on the dialysis equipment. And finally, the ISO 23500-5, that is a dialysis fluid which we are finally feeding to the dialyzer and where the dialysis is happening. Water treatment equipment. If you see this equation in this slide, you'll see that tap water is finally converted to the dialysis water with the help of a dialysis water treatment system. Why we call it water treatment system and not the reverse osmosis? In day-to-day life, generally we say that RO for the dialysis or dialysis RO, but if you see my slide, I have nowhere mentioned only reverse osmosis. It is the water treatment equipment. And this water treatment equipment is basically comprises of three main parts. That is the pre-filtration, reverse osmosis, and the water distribution system. If either of the part is not complying with the ISO 23500-2, which specifies the design of the water treatment system, it means that our water treatment system is not complying the ISO standards. So the configuration or the designing of the water treatment system, it basically converts our tap water to the dialysis water. So it is very, very important to understand what is the quality of our tap water or the feed water. What is the source of the water to our RO systems? You all might have visited to the RO treatment room, and you might have seen there that we are feeding water to the reverse osmosis or to the water treatment system. From where we are feeding water to the water treatment system, it is the tap only. At any RO room, you will see, and you will go and you will see that there is a tap which is connected at the inlet of the water treatment system. So understanding the feed water quality is very, very important, because until you'll understand what are the level of contaminants in your feed water, we won't be able to design our water treatment system to filter out all those contaminants from the tap water and to make it a usable dialysis water. What are the sources of the tap water? It can be the groundwater, it can be the surface water, it can be water from well. So level of toxicity and the kind of contaminants, it depends upon the water source. For example, if you are using the groundwater, then the level of contaminants such as heavy metals will be high. Whereas if you are using the surface water, like the water from the rivers and all, then the organic compounds contaminants will be high in that case. Generally from the rivers, when we are taking the feed water, the contents like HDI, the silt density index, are generally high. Whereas in groundwater, you will see that the iron content is high. If you go in the western belt, where in the states like Odisha, West Bengal, where the iron mines are there, so you'll find a lot of iron content in the feed water. So the quality of groundwater, it changes geographically. It varies geographically from one location to another, depending upon the geography of that area. The first section of water treatment is pre-treatment. The filters which are installed before reverse osmosis are the pre-filters, and the complete set, we call it as a pre-treatment or the pre-filtration. There are multiple type of filters which are there in this stage. If you see on first filter, this is the sand or zeolite filters. So sand filter or zeolite filters, it removes the big size particles from the water. So all the suspended particles which are there in the water are get trapped at this filter stage, and it passes to the next filter stage. Then comes the particle filters. So particle filters are generally 20 micron particle filters, 5 micron particle filters, 1 micron particle filters. And what we understand with this micron size, like 20 micron, 5 micron, 1 micron, these are basically the size of the suspended particles which get trapped in these particle filters, and the filtered water passes to the next stage. If there is an iron contaminant available in the tap water, then an iron filter is required. It oxidizes the available iron content in the feed water, and it gets trapped within the filter, and filtered water passes to the next filter cycle. Next comes the softener. What does softener do? Softener removes the hardness from the water. So clinically, our clinicians can explain very well that what will happen if hard water is passing to the patient. Hard water syndrome will be there. So to ensure that there is no hardness passing to the next filtration stage, we use softeners which effectively removes the soft hardness from the water, and soft water passes to the next filter stage. Then the chlorine filters. Chlorine filters, they are having the activated carbon molecules, and these activated carbon molecules, they are responsible for the filtration of two things. One is the chlorine filtration and other is the chloramine filtration. So chlorine gets absorbed in the activated carbon granules, and chloramines get trapped or adsorbed on the surface of the activated carbon molecules. What is activated carbon granules or molecule? Activated carbon molecules are basically the carbon granules which are coated with iodine value greater than 900 IV. So when the carbon molecules are coated with iodine, then their property changes and they are able to absorb chlorine and adsorb chloramines. So these are the different type of filters which are used in the pre-treatment section of the RO system, of the water treatment system, so that filtered water can be passed to the reverse osmosis, because reverse osmosis cannot do the chlorine or chloramine filtration. Chlorine filtration is only done at the carbon filter. Any question on this stage? On the pre-treatment? All are okay? Okay. Reverse osmosis. What is osmosis? What is osmosis? Great, thank you. So, and what is reverse osmosis? The reverse of osmosis. And how we can achieve reverse osmosis? By applying the pressure on the concentrated water side. So if we are applying the high pressure on the concentrated water side, then what is happening? Reverse osmosis is happening. It means that the clean or filtered water will go into the permeate line, and the salted or the concentrated reject water will go to the reject line. So this is what is happening in the reverse osmosis unit. But is it sufficient that we define the RO system only as a reverse osmosis principle? No, because when we are using the reverse osmosis for the dialysis patients, it should be a medical device. It should ensure the patient safety. It should ensure that the electrical circuits of these devices are electrically safe, both for patients as well as staff. So to ensure that a reverse osmosis unit, which is installed in our dialysis clinics for the dialysis purpose, are safe for the patient as well as safe for the staff. When I say that a medical device or a reverse osmosis should be a medical device and it should be safe for the patient use. What does it mean? It means that it should be having the tendency to select the water and to read or monitor the water, whether the quality of produced water is okay to feed to the patient or not. If it is not able to decide whether the quality of water which is produced by the reverse osmosis is good to feed to the patient and or not too good to feed to the patient, then it means that device is not medical grade. So the moment when reverse osmosis will sense that water quality is not up to the mark and it is not uh, uh, it is not meant to be fed to the patient, so it should drain that water to the drain line. So this is the difference between industrial grade RO systems or the RO systems which are meant for the other purposes than the dialysis purpose. At reverse osmosis, we have produced our dialysis water. Now that dialysis water from RO unit has to reach to the dialysis station. So the circuit or the path which is connecting our reverse osmosis unit to the dialysis machine should be medical grade. What does it mean? It means that the water which is produced at reverse osmosis and the water which is feeding at dialysis station, the quality of that water should not change when it is traveling from the reverse osmosis to the HD device. Also, in clinical terminology, we have heard of retrograde flow. What is retrograde flow? So retrograde flow means that a sufficient pressure should be there in the path of a flow that microbials should not travel back or into the counter direction of the flow. If microbials are able to travel in the counter direction of the flow, then microbial which may get produced in the dialysis water loop or the distribution loop, it can travel back to the dialysis machine and it can harm the patient. So to maintain the retrograde flow, there should be sufficient devices installed in the distribution water loop which can ensure that there is always there is a pressure greater than 2.5 bar within the distribution loop so that microbials cannot travel back in the counter direction of the water flow. Finally, the water reaches to the dialysis equipment and we are able to do the dialysis treatment while we are connecting our dialysis machine to the port of our distribution line. So what are the standards which defines the quality of dialysis water? In starting of my presentation, I mentioned that there are ISO standards and the latest standards for dialysis are ISO 23500. It is a chapter number 3 in ISO 23500 which defines the quality standards of water which is good for the dialysis. So if you see here in this slide, I have compared the standards of the drinking water and the standards of the dialysis water as per the ISO. If you see here, there are parameters of aluminium, total chlorine, copper, fluoride, lead, nitrate, sulfate, zinc, and other metals, which are compared with respect to the drinking water. If you see the aluminium, the permissible limit in the drinking water is 0.2 ppm, whereas in dialysis water, the permissible limit is 0.01 ppm. So if you compare both, it means that the dialysis water is 20 times clear or pure with respect to your drinking water. Drinking water which is coming in our portable bottles like Bisleri and all. Even with that water, we can't perform the dialysis because that is impure with respect to the standards which are mentioned in ISO 23500-3. These are the microbial standards which are defined in ISO 23500-3 for the dialysis water. What are the two contaminants which we have to monitor for the dialysis water? These are the colony formation units and other are the endotoxin units. So this standard says that the limit of the colony formation units per milliliter is less than 100 in the dialysis water and less than 0.25 endotoxin units per milliliter for the endotoxin units. So the quality of dialysis water is defined in ISO 23500-3, whereas the quality of these microbial limits for concentrate and dialysis fluid are defined in chapter number 4 and chapter number 5 respectively. So if you see this slide, you'll see when dialysis water is getting mixed with dialysis concentrates, that is part A and part B, this limit get exceed for the endotoxin units. If you see for the colony formation units. So if you see the colony formation unit limits, the permissible limit is less than 100, whereas for the endotoxin units, it is 0.5 as per the ISO, and as per the European Pharmacopoeia, it is 0.25. Why it is so? Why the limits of endotoxin units, when it comes to the dialysis fluid, these permissible limits are increased as compared to the dialysis water? Bicarb can be source for the endotoxin units. Very rightly said, because bicarb is just like a food where the endotoxin counts are quite high. So when it is getting mixed with dialysis water, then the endotoxin counts increases. What we can do to control this addition or increase in increase in endotoxin units at bicarb level? What practices we can use to manage this rise in endotoxin units while we are adding the bicarb to the dialysis water? Answer. Right. Right. Thank you so much, sir. So buyback is the one solution where the concentrate part B bag connected with the dialysis machine in the powder form. And when it is in powder form, then the chances of increasing of endotoxin units are very, very less. And we can manage the increase count of endotoxin units by using the buybags. Then in our earlier presentations of Dr. Manish and the rest of the presenters, we heard a word ultra pure dialysis fluid. Why it is required and how we can prepare it, how we can achieve the ultra pure dialysis fluid standards. Right, sir, and it's partially answers my question, but if I'm speaking only about the hemodialysis, even in hemodialysis, when we are using the high flux, then also the chances of contamination is very, very high. In a high flux dialyzer, the chances of contamination is very, very high, and whenever we are doing the high flux dialysis, we should ensure that the dialysate, which is prepared inside the dialysis machine, is of ultra pure standards. So if you see the dialysis devices, the HD machines, all the manufacturers, they are having the endotoxin retentive filters with their dialysis machines. Fresenius called it diasafe, and this diasafe ensures that when dialysate is passing through the diasafe, we are achieving the ultra pure standards of that dialysate. So it helps us in giving the achieving the ultra pure standards of the dialysate while we are doing the high flux dialysis. Then the substitution fluid, which is the part of hemodiafiltration. How we achieve the quality of substitution fluid, which we also call sterile fluid. So the ultra pure dialysis fluid, it again passes through the second diasafe to achieve the sterile standards where the water is getting mixed with blood. So this is how the journey of tap water to dialysis water, then ultra pure dialysate to the sterile fluid or the substitution fluid. So I'm done with my presentation. I'm done with the all the standards which are meant for the water treatment equipment and the standards for the water dialysis water and the UPDF and the sterile fluid. Any questions? I have kept nearly 15-20 minutes only for the questions on this topic. So the life of sand filter or any kind of filter, it depends upon the quality of feed water that we are supplying to the sand filter. For example, the level of contaminants are very, very high, and our sand filter is not equipped with a multi-pot valve, which can do the automatic backwash and rinse of the filter, then it will decrease the life of sand filter. If our sand filter is equipped with a multi-pot valve, which is meant for the backwash and rinse cycle of filter, then the life of sand filter will be high. Generally, if our backwash and rinse is happening at the recommended frequencies, then the life of this filter goes up to 3 to 4 years. If the feed water does not contain iron content, if the feed water has iron content less than 0.1 ppm, then we can have only sand filter in the water treatment equipment. In case the iron content is greater than 0.1 ppm in the feed water, then we have to install the iron removable media filter. From the corporation water in Delhi, from the Delhi Jal Board, we have done multiple time examination of that, and in that iron content is not available. But in South Delhi, the TDS and iron content is very high if we are using the groundwater from the boring. The TDS in South Delhi is very, very high, nearly 3400 ppm or so. Yeah, and in that case, generally, we recommend that we should have a primary industrial grade RO system, which first converts that that water to the drinking quality water standard, and then we can feed it to the medical grade water treatment systems, which can achieve the dialysis water standards. So, in such cases where the TDS is very, very high, then water efficiency or the water availability becomes very, very challenging, because if we are installing too many water treatment systems, then we are rejecting a lot of water which is going into the drain, and we are not able to utilize that. Generally, this kind of water treatment system, they are available up to the efficiency of 75%. So when I say 75% efficiency, it means 3 parts you are utilizing and 1 part you are rejecting. So it depends how. True. Yes, ma'am. Right, right, right. But it all depends upon the, you can say, the quality standard, the advanced technology of the reverse osmosis. Uh, uh, Actually, the efficiency of this reverse osmosis system, it should be dynamic in nature. For example, if the conductivity of the feed water is increasing, then the rejection of reverse osmosis should be increased. And if the conductivity of the feed water is decreasing, then the efficiency should be increased. So what does it mean? That the rejection of water should adjust by itself with respect to the feed water conductivity. Also, for example, if you are having a central water treatment equipment, which is meant for running 10 dialysis stations. And at that moment, you are not running all the 10 dialysis stations, only 1 or 2 are connected. If the efficiency of that RO system is not dynamic in nature, then it will keep rejecting 50 to 75% of water, irrespective whether you are consuming that water or not. But if you are having the reverse osmosis system with a dynamic efficiency, then you will be feeding that water back to the reverse osmosis, and it will consume that much feed water which is required to run only 1 or 2 dialysis stations. So in that way, we save a lot of water, and it is a social cause. 22nd March is a World Water Day, which is coming up, and we are doing a lot of programs. Yes, true. Right. True, man. True. So water efficiency of water treatment system in hemodialysis plays a vital role in water saving. Thanks for asking this question, man. So PEX piping, it depends upon the recommendation from the manufacturer. For example, companies like Fresenius, they certify this product for 10 years. Like if you are installing the PEX pipe uh, in current year, so after 10 years, till 10 years, there will be no problem in using the same distribution loop. Risk of biofilm generation is always there. So for that, there are disinfection methods which are prescribed. It can be the hot water disinfection method or the chemical disinfection method. So hot water disinfection method is a proactive measure. Whenever you are doing the hot water disinfection method, you'll be available with the mode of doing the hot disinfection of the distribution loop, and you will be able to prevent the biofilm formation. In chemical disinfection method, generally we are doing the disinfection of the distribution loop whenever you are observing the growth in the distribution loop. So these are the reactive measures, the chemical disinfection, and hot water disinfection is the proactive measures. There is a term which is called as rejection rate. So for example, at the time of the installation, we are measuring that what is the TDS or conductivity of the input water, and then we are measuring the conductivity of the output water. So with the help of these two factors, we calculate the rejection rate, that how much salt is rejected by the membrane. Generally, if the membrane is rejecting salt more than 90% to 96%, it means your membrane are good to use. In case the membrane rejection rate is decreasing below 90%, then it means we should replace the membrane. So rejection rate is one factor, and another factor is the output flow. If the capacity of a membrane is 500 liter per hour, and if the flow of that membrane drops down below 450, and even after the decalcification of that membrane, we are not getting the optimum flow, then we should replace the membrane. So disinfection of RO system, as per ISO, it says that this frequency should be mentioned by the manufacturer of the equipment. And at Fresenius, for the direct feed RO systems, we mentioned that till the time microbials are not visible in our RO testing report, we can ignore the disinfection. And but mandatorily once in a 2 year, it is advisable that we should do, irrespective whether these are visible in our water test report or not. But in India, practice is like that. Chemical disinfection is being done once in a quarter, and hot water disinfection is done once in a 15 days or a month. So there are two types of water testing. One is for the chemical contaminants, and other is for the microbial contaminants. ISO says in case you are having the endotoxin retentive filters on all of your dialysis machines, then the return water from the loop should be tested once in a quarter, but practice in India is every month. And the chemical contaminants should be checked for the product water as well as the feed water once in a year.
हीमो फिल्ट्रेशन करना चाहते हैं तो वाटर टेस्टिंग का सैंपल है वो कहाँ से लेना चाहिए?
So the hemodiafiltration or the standard dialysis, if you go through these standards, there are no as such, you can say the different testing processes are given. Testing process for the dialysis water, for the feed water, for the dialysate are standard for all kind of dialysis. Fine. Thank you.
After the talk, very informative talk on water treatment in hemodialysis, we move on to another important topic, disinfection of the hemodialysis machine. For this, it is my pleasure to invite Mr. Som Sharma and then Dr. Puneet from AIMS for this. Mr. Som Sharma. So Puneet, you will be doing first? Okay.
Thank you, Mr. Raghuvar, for a nice talk on the water treatment. So next we will be discussing now disinfection of dialysis unit. It's a very important and a very practical topic. In disinfection, we all know it removes most of the harmful organisms, and also it is required for decalcification and smooth functioning of the machines. And chiefly, basically, it is done either by chemical or heat methods. So in our class, we'll be discussing we'll be focusing on the chiefly the disinfectants used and the various programs which are used for the disinfection of SD machines. And briefly, we'll also be touching upon the disinfections of the outer surface of SD machine as well as the dialysis station. So for class, I'll request our dialysis staff, Mr. Som Sharma, to please conduct the class.
Thank you, Dr. Puneet, for introduction. Today my topic is disinfection of dialysis machine. So all are mostly हम लोग डेली ड्यूटीज में डिसइंफेक्शन कर रहे हैं, तो ज्यादातर लोग अवेयर हैं कि हम लोग कैसे कर रहे हैं और क्या करना है, लेकिन उसको अपडेट करना है थोड़ा सा और उसको अपग्रेड करना है कि क्या गलत कर रहे हैं, तो उसके रिगार्डिंग थोड़ा सा इंफॉर्मेटिव प्रैक्टिकल नॉलेज है, ज्यादातर फोकस प्रैक्टिकल के ऊपर है. तो सो आई एम गोइंग थ्रू. सबसे पहले डेफिनेशन, सबसे पहले डेफिनेशन के बारे में बात करेंगे. डिसइंफेक्शन क्या है? जैसे कि हम लोगों को पता है डिसइंफेक्शन इज द रिमूवल ऑफ द पैथोजेनिक माइक्रो ऑर्गेनिज्म एक्सेप्ट बैक्टीरिया स्पोर्स. तो इसका यदि हम तुलना करने लगे हैं स्टेरिलाइजेशन से कैसे डिफरेंट है, तो सिंपली स्टेरिलाइजेशन में सब कुछ एवरीथिंग मतलब ऑल फॉर्म ऑफ बैक्टीरियल और स्पोर एवरीथिंग खत्म हो जाता है, जबकि डिसइंफेक्शन में स्पोर्स नष्ट नहीं हो पाते हैं। एक बेसिक नॉलेज है। इसके बाद नेक्स्ट स्लाइड में हम जाएंगे कि हम लोगों को क्यों डिसइंफेक्शन की करना है। तो डिसइंफेक्शन की नेसेसरी क्या जरूरत क्यों पड़ी हमको, तो आप लोगों में कोई बता पाएगा क्यों, मतलब मशीन का डिसइंफेक्शन क्यों चाहिए? आरओ का डिसइंफेक्शन हम करते हैं, डायसेप भी लगाते हैं, और आरओ के अंदर बहुत सारे प्रोटेक्टिव आरओ मेम्ब्रेन्स हैं, यूवी लाइट है और डायसेप भी है, उसके बाद भी मशीन का भी डिसइंफेक्शन फिर भी करना है हमको। तो एनीवन एक्सेप्ट एम्स क्यों भाई भी नेसेसरी डिसइंफेक्शन बाय द मशीन्स। चलिए इसका 2-3 ही रीजन है मेनली। सबसे पहला तो यह है कि आपको टू रिड्यूस माइक्रोवेल पैथोजन एंड प्रिवेंट ट्रांसमिशन इन्फेक्शन बिटवीन पेशेंट्स। सिंपली आप नहीं करोगे तो उसका रीजन आप जैसा कि बताया नियर अबाउट 4 आवर सेशन में हम लोग 120 लीटर से लेके 200 लीटर तक आरओ वाटर का और विद डायलिसिस हम क्रॉस करते हैं इंटरनल पाथवे में। सो थोड़ा सा भी अमाउंट वायकार का अंदर रहता है या आपका ह्यूमिडिटी रहती है और आप कुछ नहीं करते हो, नथिंग, छोड़ दिया मशीन को, डायलिसिस करा और 2 दिन के लिए छोड़ दिया, तो ड्यू टू ह्यूमिडिटी ड्यू टू वायकार अब अगली बार हो सकता है मशीन आपकी चले ही नहीं। सो डिसइंफेक्शन तो नेसेसरी है ही। इसके बाद सेकंड पॉइंट है टू रिमूव कैल्सिफिकेशन फ्रॉम हाइड्रोलिक सिस्टम एंड प्रोलॉन्ग लाइफ ऑफ मशीन। ऑब्वियसली यदि हम रेगुलर डिसइंफेक्शन करेंगे तो कैल्सिफिकेशन नहीं होता, कैल्सिफिकेशन रिमूव करते हैं डिसइंफेक्शन से। तो और यदि ये करते रहेंगे तो लाइफ ऑफ मशीन्स विल इंक्रीज। जैसा कि हमारे यहाँ हम 10 ईयर तक मशीन्स को यूज करते हैं और ऊपर भी जाने की कोशिश करते हैं। तो टू प्रिवेंट माल फंक्शन ऑफ मशीन्स एक्चुअली रेगुलर मेंटेनेंस होगा अपनी साइड से भी, इंजीनियरिंग साइड से भी, तो आपकी मशीन में माल फंक्शन कम आएंगे। आप डायलिसिस लगाने जा रहे हो, मशीन बैठ गई, तो ये सब चीजें आप रोक सकते हो रेगुलर यूज से। इसके बाद क्वेश्चन आता है कि कब करना है, मतलब करना कब है वो भी तो पता होना चाहिए। मतलब तो ऑब्वियसली आप ज्यादातर लोगों को पता होगा कब करते हैं। तो आफ्टर ईच सेशन और एटलीस्ट वंस ए डे। इसमें और एटलीस्ट वंस ए डे इसलिए कहा गया है कि हो सकता है आपका सेशन बहुत बिजी है, आपके पास टाइम नहीं है 45 मिनट्स या 30 मिनट्स का, तो एक्चुअली आइडियल है आफ्टर ईच डायलिसिस सेशन। लेकिन कभी कभार आप हो सकता है एंड ऑफ द डे कर लो, मतलब वीकली आइडियल नहीं है। उसके बाद आता है सेकंड आफ्टर एन एपिसोड ऑफ ब्लड लीक इनटू द डायलिसिस। यदि आपको ये कंफर्म है, आपको लगता है कि डायलिसिस मेम्ब्रेन डायलिसिस मेम्ब्रेन का रप्चर हुआ है, मिक्सिंग ऑफ विद ब्लड हुआ है डायलिसिस, तो उस कंडीशन में भी आपको डिसइंफेक्शन करना है। क्योंकि वहां पे प्रोटीन रिलीज होता है जो काफी लंबे समय तक अंदर रह सकता है। इफ सर्विलेंस कल्चर शो हाई सीएफयू और एंडोटॉक्सिन लेवल, जैसा कि सर ने अभी पिछली टॉक में बताया है कि सीएफयू लेवल और एंडोटॉक्सिन लेवल से ज्यादा है। यदि सीएफयू लेवल ग्रेटर देन 100 है और एंडोटॉक्सिन लेवल ग्रेटर देन 0.25 है, यदि मशीन से यदि आरओ लेते हैं, वाटर लेते हैं टेस्टिंग के लिए, तो आपको डिसइंफेक्शन मशीन का सेपरेटली करना है, आरओ का तो अलग इंडिकेशन है। आफ्टर मशीन मेंटेनेंस, ये इंजीनियरिंग पार्ट है। हमारे जैसे इंजीनियर्स आते हैं और आपका मशीन को मेंटेनेंस में करना है, उनको अंदर इंटरनल पाथवे से रिगार्डिंग, मतलब डायलिसिस जहाँ से बनता है उस चीज के रिगार्डिंग वो कुछ छेड़ते हैं, और आप मेंटेनेंस आप उसके बाद डायलिसिस नहीं करोगे, देयर इज रिस्क ऑफ इन्फेक्शन, मतलब वहाँ पे हो सकता है कि इसीलिए आपको ये करना चाहिए आफ्टर लॉन्ग इनएक्टिविटी ऑफ मशीन। जनरली कई बार ऐसा होता है कि हम 2 या 3 मशीन को लगातार यूज कर रहे होते हैं, स्टैंड बाई हमारी मशीन रखी है, तो आपको बहुत लंबे समय तक मशीन को ऐसे नहीं छोड़ना है, और उसको एक निश्चित समय, जैसे कि हमारे यहाँ कितना भी हो जाए, हम विदिन करते ही हैं 3 to 4 डेज में मशीन का डिसइंफेक्शन हम करते ही हैं, यदि वो स्टैंड बाई भी खड़ी हुई है तो। फ्रंट डिसइंफेक्शन एटलीस्ट वंस ए वीक, तो फ्रंट डिसइंफेक्शन एटलीस्ट वंस ए वीक, इसके एक सप्ताह में एक बार फ्रंट डिसइंफेक्शन करना है। इसके रिगार्डिंग डिटेल में आगे बात करेंगे। इसके बाद नेक्स्ट क्वेश्चन आता है कि व्हाट ऑल नीड्स डिसइंफेक्शन, मतलब हम किस चीज का डिसइंफेक्शन कर रहे हैं मशीन के अंदर। तो एक्चुअली दीज ऑल आर द इंजीनियरिंग पार्ट, मशीन के अंदर फिटेड रहते हैं, ऑब्वियसली हम लोगों ने बहुत सारे लोगों ने देखा नहीं होगा कि क्या होता है, तो ये लेकिन पता होना चाहिए कि क्या किस चीज का हम कर रहे हैं। बैलेंसिंग चैम्बर है, फ्लो पंप है, यूएफ पंप है, डिगैसिंग पंप है, कंसंट्रेट पंप है, एसिड एंड बाइकार्ब जो बनाता है अंदर, एंड रिंस चैम्बर है, रेड एंड ब्लू, एंड कंसंट्रेट सक्शन ट्यूब्स, हीटर ब्लॉक, डायसर प्लस फिल्टर। डायसर प्लस फिल्टर तो सबने देखा ही है। तो इसके बाद है कि क्वालिटी ऑफ एडी डिसइंफेक्टेंट, हम जो भी डिसइंफेक्टेंट यूज कर रहे हैं उसका मतलब उसके अंदर होना, मतलब क्या कम से कम वो क्या चीज करे कि वो मस्ट है। तो एक एडी डिसइंफेक्टेंट के अंदर देखो वो डिसइंफेक्ट तो करता ही है, फर्स्ट प्रायोरिटी डिसइंफेक्टिंग अच्छे से करना चाहिए। सेकंड में है रिमूवल ऑफ कैल्शियम कार्बोनेट, तो ये भी नेसेसरी है क्योंकि ज्यादातर हमारा डायलिसिस में सब हम कैल्शियम बाइकार्ब का यूज करते हैं, तो रिमूवल कैल्शियम कार्बोनेट जरूरी है। इसके बाद डिटर्जेंसी जनरल क्लीनिंग भी होनी ही है, ये भी नेसेसरी पॉइंट है। जनरल क्लीनिंग में डर्ट या एनीथिंग चीजें। अब इसके बाद डिसइंफेक्शन प्रोसेस के बारे में थोड़ा सा जनरल नॉलेज है। डिसइंफेक्शन ऑफ द मशीन इज परफॉर्म्ड यूजिंग आइदर ब्लीच और सिट्रोस्टिल प्यूरिस्टिल। तो तीनों ही चीजें सिट्रोस्टिल, जैसे कि हम लोग ज्यादातर फिजिनस का मशीन यूज करते हैं, और आई थिंक मोस्टली लोग फिजिनस का यूज कर रहे हैं यहाँ पे जो है। तो सिट्रोस्टिल, प्यूरिस्टिल और ब्लीच, ये तीन डिसइंफेक्टेंट है। स्टैंडर्ड डिसइंफेक्टेंट इज फिटेड टू रियर ऑफ डायलिसिस मशीन। सभी को पता ही होगा कि ये डिसइंफेक्टेंट ये रियर ऑफ द मशीन के पीछे आपका फिक्स रहता है। कोई आप दोनों होते हैं, सिट्रो भी आप फिक्स कर सकते हैं और साथ साथ आप प्यूरी भी वहाँ पे फिक्स कर सकते हैं। प्रोसीजर परफॉर्म बाय डेजिग्नेटेड पर्सन इन डायलिसिस यूनिट। एटलीस्ट पर्सन जो डिसइंफेक्शन कर रहा है उसको नॉलेज होनी चाहिए कि वो क्या करना चाह रहा है, मतलब कौन सा प्रोग्राम में डालना है और किस तरह से डालना है। इसके अलावा पीपी प्रॉपरली पहन के करना है क्योंकि इट मे बी हार्मफुल। गाउन पहनना है एंड ग्लोव्स, कैप एंड प्रोटेक्टिव ग्लासेस मस्ट बी worn. The step of disinfection should follow the guideline recommended by the manufacturer. एक इम्पोर्टेंट बात है, मतलब आप जो चाहो वो नहीं कर सकते, मतलब आपको मैन्युफैक्चरर की गाइडलाइन को फॉलो तो करना ही पड़ेगा। मतलब जो वहाँ पे मिनिमम बताया, मिनिमम इंडिकेशन ये है तो फॉलो करना ही है। हैंड हाइजीन शुड बी स्ट्रिक्टली फॉलोड। मतलब कोई भी काम आप डायलिसिस में हो या कहीं भी हो, हैंड हाइजीन तो ऑलवेज इंपॉर्टेंट इन मेडिकल फील्ड। तो बार बार हाथ धोते रहना है, 6 स्टेप हैंड वॉशिंग करनी है, बेसिक मूवमेंट 5 मूवमेंट्स का ध्यान रखना है, वो ऑलवेज आपको फॉलो करना है। इसके बाद यहाँ पे अब एक पिक्चर देख पा रहे हैं आई थिंक, तो इस पिक्चर के अंदर आप डिफरेंट टाइप्स ऑफ प्रोग्राम देख पा रहे हैं। तो जब भी आप क्लीनिंग मेनू प्रेस करके अप एंड डाउन की होती है मशीन के, वो भी आप देख पा रहे हैं। तो इस अप एंड डाउन की प्रेस करके आप किसी भी उस प्रोग्राम पे जा सकते हैं, एंड देन कंफर्म बटन आप प्रेस करोगे तो ये मेनू ये प्रोग्राम सेलेक्ट हो जाएगा, देन मशीन उसमें चली जाएगी। तो अभी इन्हीं प्रोग्राम्स के बारे में हम डिटेल्स में एक एक करके नॉलेज प्राप्त करेंगे। इसमें ऊपर का जो प्रोग्राम, आप 3 प्रोग्राम हॉट रेंज एंड विदाउट कूलिंग रिंग्स एंड इंटीग्रेटेड हॉट रेंज, ये जस्ट क्लीनिंग प्रोग्राम है। नीचे वाले जो 5 प्रोग्राम आप देख पा रहे हैं, डिसइंफेक्शन, हॉट रेंज और हॉट डिसइंफेक्शन प्लस हॉट रेंज, ये डिसइंफेक्शन प्रोग्राम है। तो इन सब के बारे में हम एक एक करके बात करेंगे। अब इसके अंदर प्रोग्राम साइकिल डेफिनेशन, एक्चुअली आप जब भी हम डिसइंफेक्शन करते हैं तो एक एब्रीविएशन आपने देखा होगा ऊपर, बहुत सारे लोगों ने नोटिस किया होगा कि जब आपको हॉट डिसइंफेक्शन में मशीन को डाल दिया है तो आपको ऊपर दिखाएगा FHDISM। तो उन सब चीजों का आपको एक्चुअली तो आपने डाल दिया, हॉट डिसइंफेक्शन हो रहा है, सबको पता है, लेकिन हो क्या रहा है अंदर, मतलब किस तरह से हो रहा है वो भी थोड़ा सा पता होना चाहिए। पहले एब्रीविएशन के बारे में बताऊंगा। तो यदि वहाँ F होता है तो इसका मतलब फ्री रिंस है। उसके बाद D फॉर डिसइंफेक्शन, DF दैट मीन क्लीनिंग फ्रंट सप्लाइड, आप फ्रंट डिसइंफेक्शन कर रहे हो, ठीक है। HDIS हॉट डिसइंफेक्शन, M फॉर मैंडेटरी रिंस, HR फॉर हॉट रिंस, देन सेम नीचे भी सेम ही है, R एंडलेस फॉर एंडलेस रिंस, IHR इंटीग्रेटेड हॉट रिंस, C फॉर कूलिंग रिंस। तो ये सब ये एब्रीविएशन हैं जो कि यूज होते हैं, आगे की पिक्चर्स में इसके बारे में पता चलेगा। अब ये प्रोग्राम, जितने भी प्रोग्राम हमने देखे थे पहले उस पिक्चर के अंदर, तो उसके अंदर ये R फॉर रिंसिंग, R एंडलेस, मतलब लंबे टाइम तक रिंसिंग, FHRC, ये हॉट रिंसिंग। तो ये सब चीज, ये प्रोग्राम लास्ट में डिसइंफेक्शन के प्रोग्राम है 5 जिसके बारे में हमने बात करा था। तो इन प्रोग्राम्स का ये इनके एब्रीवेशंस हैं। चॉइस ऑफ डिसइंफेक्टेंट आपकी क्या हो सकती है? जनरली इसे 3 तरह से ही हम कर रहे हैं, हॉट डिसइंफेक्शन करते हैं या कोल्ड डिसइंफेक्शन करते हैं या फिर ठंड डिसइंफेक्शन करते हैं, जिसको कि डीग्रीसिंग या ब्लीच डिसइंफेक्शन भी बोलते हैं। तो कोल्ड डिसइंफेक्शन किससे करते हैं? तो ये प्यूरिस्टिल से हम लोग कर रहे हैं, प्यूरिस्टिल प्लस करके आता है, और मिक्सचर ऑफ एसिडिक एसिड, हाइड्रोजन पेरोक्साइड, पैरासिटिक एसिड एंड हाइड्रोजन पेरोक्साइड। हॉट डिसइंफेक्शन सिट्रोस्टिल के थ्रू किया जाता है, मिक्सचर ऑफ लैक्टिक एसिड, मैलिक एसिड एंड सिट्रिक एसिड। और ठंड डिसइंफेक्शन जो हम करेंगे वो सोडियम हाइपोक्लोराइड का यूज करते हैं। कंपनी मेड की बात करें तो स्पोर्ट करके आता है, जो आई थिंक नहीं यूज कर रहे हैं, हम फ्रेश मेड यूज करते हैं 1% हाइपोक्लोराइड से। डिसइंफेक्टेंट यूज आपको ये FDM, दैट मीन ये है आपका डिसइंफेक्शन, कोल्ड डिसइंफेक्शन है। ये किससे होगा? एक्चुअली प्यूरिस्टिल यूज किया जाता है कोल्ड डिसइंफेक्शन के लिए, और सिट्रोस्टिल यूज किया जाता है हॉट डिसइंफेक्शन के लिए। और लास्ट में आप देख पा रहे हैं स्पोर्टर और हाइपोक्लोराइड, दीज ऑल आर, ये चीज यूज की जाती है आपकी फ्रंट डिसइंफेक्शन, जब आप फ्रंट से डिसइंफेक्शन कर रहे हैं। इसके बाद प्रोग्राम्स के ऊपर एक एक करके प्रोग्राम्स पे आएंगे। रेंज, जैसे कि आप यहाँ एब्रीवेशन में मैंने पहले बात की थी, R देख पा रहे हैं, R फॉर ओनली रिंसिंग। तो रिंसिंग है क्या? रिंसिंग लगभग 16 मिनट्स का एक प्रोग्राम है, जिसके अंदर नॉर्मल टेम्परेचर 36-37 डिग्री टेम्परेचर पे फ्लशिंग ऑफ इंटरनल हाइड्रोलिक्स ऑफ मशीन विद वाटर एट 36, मतलब केवल फ्लशिंग होता है वाटर का। अब और यहाँ पे आप एक पिक्चर देख पा रहे हैं, ये ग्राफ है विद कंप्लीशन एंड द टेम्परेचर। तो ये ब्लू करके ये सारा केवल हम वाटर यूज कर रहे हैं, तो ये ब्लू से डिनोट किया है, और केवल रिंसिंग चल रहा है, इसके अलावा इसमें कुछ भी नहीं है। 16 मिनट का करीब प्रोग्राम है। तो इस रिंसिंग का ये है, रिंस शुड बी डन इफ रेसिडुअल डिसइंफेक्शन टेस्ट इज पॉजिटिव। यदि आप कोई डिसइंफेक्शन आपने प्रोग्राम डाला है, आपने डाला है कोल्ड डिसइंफेक्शन, प्यूरिस्टिल से कर रहे हो, तो आपको रिंसिंग मैंडेटरी है। वैसे प्रोग्राम के अंदर सेल्फ रिंसिंग है लास्ट में। तो यदि वो टेस्ट पॉजिटिव आता है, टेस्ट का मतलब आपको रेनिन डिस्ट्रिक्ट या फिर पोटेशियम आयोडाइड डिस्ट्रिक्ट से आपको टेस्ट करना है, और यदि वो पॉजिटिव आता है तो रिंसिंग मैंडेटरी है। वो रिंस आप हो सकता है कि 15 मिनट के लिए करो, यदि वो नेगेटिव आती है हो सकता है 1 घंटे तक करो, जब तक कि वो नेगेटिव आना चाहिए। आर एंडलेस कैन बी यूज आफ्टर सेंट्रल आरओ डिसइंफेक्शन। तो जो एंडलेस रिंस की हम बात कर रहे हैं, वो सेंट्रल आरओ डिसइंफेक्शन में जनरली यूज किया जाता है, क्योंकि सेंट्रल आरओ डिसइंफेक्शन में जो केमिकली यूज करते हैं वो पूरे लूप तक जाता है, और वो मशीन तक, लूप से लेके मशीन तक। तो इसके लिए आपको मशीन को काफी टाइम तक रिंस करना है, जब तक कि वहां पे जो रेसिड्यू की बात की थी वो नेगेटिव नहीं आ जाए। उसके लिए स्ट्रिप्स आती है, उसे चेक कई टाइम चेक करना है जब तक कि वो नेगेटिव नहीं आ जाए। रिंसिंग अलोन विदाउट द यूज ऑफ डिसइंफेक्टेंट विल नॉट किल बैक्टीरिया एंड वायरस। मतलब रिंसिंग एक जस्ट प्रोग्राम है फ्लशिंग ऑफ वाटर, उसके अलावा आप सोचो कि बैक्टीरिया मर रहे हैं या कुछ, मतलब एक जस्ट प्रोग्राम। रिंसिंग साइकिल आर टू बी यूज इन कंजक्शन विद डिसइंफेक्शन साइकिल। तो एक्चुअली इस चीज के लिए बना है कि एक कंजक्शन विद डिसइंफेक्शन साइकिल के साथ आपको यूज करना है। रिंसिंग साइकिल शुड नॉट बी यूज एज ए सब्स्टिट्यूट ऑफ डिसइंफेक्शन साइकिल। आप केवल रिंस करके आप सोचो डिसइंफेक्शन कर दिया, ऐसा नहीं है। तो आपको हमेशा रिंसिंग अलग चीज है, डिसइंफेक्शन अलग चीज है, दोनों को अलग अलग करके देखना होगा। इसके बाद आप ये हॉट रिंस नेक्स्ट प्रोग्राम है, क्लीनिंग प्रोग्राम चल रहा है। इसके अंदर आप एब्रीविएशन देख रहे हैं FHRC, जिसके बारे में बात की थी। तो आप यहाँ देख रहे हैं F फॉर फ्री रिंस, दैट मीन शुरू में जो आप ब्लू करके नीचे पिक्चर में देख रहे होंगे कि ये ब्लू करके, तो शुरू में बिगिनिंग में आरओ वाटर इंटरनल हाइड्रोलिक्स में फ्लो करता है। उसके बाद जो मिक्सचर ऑफ डिसइंफेक्टेंट, जो भी डिसइंफेक्टेंट यूज करें, जो कि सिट्रो यूज करते हैं इसमें, वो मिक्सिंग होता है इस आरओ वाटर के साथ में। उसके बाद टेम्परेचर अप होता है, उसके बाद फिर टेम्परेचर होने के बाद लास्ट में C फॉर कूलिंग रिंस। तो टेम्परेचर अप है तो वो कूलिंग होगा, वो कूल होके लास्ट में आप दोबारा ब्लू जो देख रहे हैं, तो ये कूल होके नॉर्मल टेम्परेचर में मशीन आ जाती है। दिस प्रोग्राम इज ओनली हीट क्लीनिंग, एसिड अभी नहीं होते हैं। बिटवीन % when decalcification is not required. Hot rinse alone does not disinfect the system. Hot rinse at the temperature of 80 to 90 degree kills some bacteria, क्योंकि टेम्परेचर के थ्रू कुछ बैक्टीरिया मरते हैं। अब डिसइंफेक्शन का सब्स्टिट्यूट नॉट रिकमेंडेड टू यूज एज ए सब्स्टिट्यूट ऑफ डिसइंफेक्शन। इंटीग्रेटेड हॉट रिन एक प्रोग्राम है जो कि क्लीनिंग प्रोग्राम में हम देख रहे थे, IHR करके। तो ये IHR करके हमारे आरओ सिस्टम, छोटे आरओ सिस्टम में प्रोग्राम जनरली नहीं होता है। जो बड़े आरओ सिस्टम में आई थिंक 500 लीटर या उससे ऊपर के में हॉट फीड करके एक प्रोग्राम होता है। उसके अंदर वो लोग हॉट फीड करके तो पूरा आरओ से लेके और मशीन तक हॉट रिंसिंग होगा। तो ये एलिमिनेट बैक्टीरिया बिटवीन द सेंटर आरओ लूप एंड मशीन लूप। एप्लीकेबल ओनली विद द सेंट्रल आरओ हैविंग अ हॉट रिंस फंक्शन। जो जिन आरओ में होता है वहीं पे एप्लीकेबल है ये। इसके बाद अब डिसइंफेक्शन प्रोग्राम के बारे में स्लाइड आई है। हॉट डिसइंफेक्शन, तो आप सबसे पहले मैं एब्रीविएशन की बात करूंगा जिसके बारे में पता होना चाहिए। FHDISM। F फॉर फ्री रेंज बिगिनिंग में होगा, उसके बाद डिसइंफेक्शन होगा, मिक्सिंग ऑफ डिसइंफेक्टेंट, टेम्परेचर अप, और पूरा डिसइंफेक्शन प्रोसेस होगा करीबन 15-20 मिनट तक। उसके बाद मैंडेटरी रिंस होगा, क्योंकि आपको जो केमिकल दिया है उसको निकालना भी जरूरी है, तो रिंसिंग इसलिए जरूरी है। लास्ट में प्रीसेट है इन प्रोग्राम्स के अंदर। टाइम लगभग 30 to 35 मिनट्स लगता है हॉट डिसइंफेक्शन या और टेम्परेचर हॉट डिसइंफेक्शन के अंदर 84 डिग्री पे होता है। केमिकल यूज सिट्रोस्टिल, डायस्टिल, डिकैल्सिफिकेशन, हीट क्लीनिंग और परफॉर्म साइमल्टेनियसली। दोनों चीजें वाला हीट क्लीनिंग भी होगी और डिकैल्सिफिकेशन भी होगा हॉट डिसइंफेक्शन के अंदर। कैन बी यूज फॉलोइंग एवरी बाइकार्बोनेट डायलिसिस ट्रीटमेंट। हर बाइकार्बोनेट डायलिसिस के बाद हॉट डिसइंफेक्शन करना चाहिए। हम जो केमिकल सिट्रोस्टिल यूज करते हैं उसका ये पिक्चर है। 5 लीटर का कैन है सिट्रोस्टिल, सिट्रिक एसिड सॉल्यूशन कंटेन सिट्रिक एसिड, अनहाइड्रेटेड मैलिक एसिड एंड लैक्टिक एसिड एट टेम्परेचर ऑफ 84 डिग्री सेंटीग्रेड। परफॉर्म थर्मोकेमिकल डिसइंफेक्शन at pH 1.7 to 2 and has bactericidal, virus inactivating and fungicidal action। तो ये थर्मोकेमिकल डिसइंफेक्शन है, मतलब हीट का भी उपयोग कर रहा है और केमिकल भी है। मैकेनिज्म ऑफ एक्शन की बात करें तो डिस्ट्रक्शन कैसे करता है। डिस्ट्रक्शन ऑफ फॉस्फोलिपिड लेयर, ये इंट्रासेलुलर पीएच बैलेंस को डिस्टर्ब करता है। फॉर्मेशन में कैल्शियम, मैग्नीशियम साल्ट और साल्ट कॉम्प्लेक्सेज का स्टॉप करता है। एक्टिविटी स्ट्रांगली इंक्रीज बाय इंक्रीज इन टेम्परेचर। जितना टेम्परेचर बढ़ाते हैं उतना अच्छा रिजल्ट मिलते हैं। इसके बाद आता है कोल्ड डिसइंफेक्शन। जैसा कि देख पा रहे हैं पिक्चर के अंदर FDM, फ्री रेंज डिसइंफेक्शन एंड मैंडेटरी रेंज। सो टाइम वही 30 to 35 मिनट्स। टेम्परेचर नॉर्मल टेम्परेचर पे 37 डिग्री टेम्परेचर प्रोसेस होता है। डिकैल्सिफिकेशन एंड डिसइंफेक्शन है 37 डिग्री। 10 प्यूरिस्टिल प्लस का हम यूज करते हैं। सॉल्यूशन ऑफ पैरासिटिक एसिड एंड हाइड्रोजन पेरोक्साइड। मैकेनिज्म ऑफ एक्शन है डैमेज ऑफ सेल वॉल थ्रू ऑक्सीडेशन ऑफ मेम्ब्रेन प्रोटीन, फैटी एसिड एंड DNA। किल माइक्रोब्स इंक्लूडिंग एंड ब्लड वायरसेज। Residual hydrogen peroxide can lead to methemoglobinemia. Strips of potassium iodide are used to check for residual activity after machinist। इसके अंदर एक्चुअली हाइड्रोजन पेरोक्साइड है। तो ये जो डिसइंफेक्शन प्रोग्राम है कोल्ड डिसइंफेक्शन, इसमें थोड़ा ज्यादा सावधानी की जरूरत है। आप यदि करते हैं और किसी बच्चे में मेथेमोग्लोबिन के बारे में ये बताया, यदि इस तरह सिम्टम्स है, ब्लू हो जाता है, ऑक्सीजन मेंटेन नहीं हो रहा है, सैचुरेशन, टैकीकार्डिया हो रहा है, तो आपको स्टिप से आपको देखना है कि डायलिसेट में अपना जो आरओ वाटर है उसके अंदर कहीं पेरोक्साइड रिमेन तो नहीं है, क्योंकि ये क्लोरीन रिलीज करता है। और जो ये हम जो बात कर रहे हैं पोटेशियम आयोडाइड स्ट्रिप की, ये क्लोरीन, आयोडीन और पेरोक्साइड को डिटेक्ट करती है। तो इससे आपको यदि ऐसा है तो आपको पहले रिंसिंग डालना है। आप उसको प्रोग्राम, और उसके लिए मेथिलीन ब्लू का यूज कर सकते हैं और या फिर एस्कॉर्बिक एसिड। इसके रिगार्डिंग हम अभी तक मैंने तो एक केस देखा है, शायद आप लोगों ने पता नहीं देखा नहीं देखा है। इसके बाद डिग्रीसिंग और फ्रंट डिसइंफेक्शन। जैसे कि डिग्रीसिंग मैंने पहली वाली स्लाइड में बताया था कि हम लोग सोडियम हाइपोक्लोराइड फ्रेश मेड यूज करते हैं। कंपनी मेड स्पोर्टल करके फ्रीजर्स का शायद आता है। कैन बी यूज फॉलोइंग एनी ब्लड लीकेज इनटू द मशीन। यदि ब्लड लीकेज कंफर्म है तो डिग्रीसिंग करना है, फ्रंट डिसइंफेक्शन करना ही है। डिग्रीसिंग और फ्रंट डिसइंफेक्शन टाइम 35 मिनट तक लगता है। फ्री रिंस पहले होगा, 3 मिनट्स का फ्री रिंस होता है। उसके बाद 2-3 मिनट के अंदर डिसइंफेक्टेंट मिक्सिंग होता है। टेम्परेचर नॉर्मल रहता है 37 डिग्री के करीब। उसके बाद डिसइंफेक्शन प्रोसेस होता है 15 मिनट 20 मिनट्स के करीब। उसके बाद लास्ट में आपका ये ब्लू वाला मैंडेटरी रिंस होगा। इस तरह से ये प्रोग्राम कंप्लीट होता है। 1 to 3% सोडियम हाइपोक्लोराइड, जिसको कि ब्लीच या स्पोटर 100 सॉल्यूशन यूज्ड टू disinfect the filter at the back of machine diasep. Actually the diasep filter can be disinfected up to 11 times. ये शायद सभी लोगों को पता होगा कि 11 टाइम्स का यदि कंप्लीट हो गया है 11 टाइम फ्रंट डिसइंफेक्शन, और उसके बाद आप diasep filter आपको चेंज करना ही पड़ेगा। ये 3 मंथ या 100 सेशन वाला थ्योरी भी मालूम होगा। So diasep filter can be disinfected up to 11 times, good for disinfecting and degreasing once a week or after blood leakage. Not for decalcifying. Decalcification नहीं होता है फ्रंट डिसइंफेक्शन के अंदर। डन एट 37 डिग्री। मैकेनिज्म ऑफ एक्शन की होता है रिएक्शन ऑफ द रिलीज क्लोरीन विद ऑर्गेनिक सब्सटेंसेस, सेल वॉल एंड सेल प्रोटीन। इसके बाद जनरली हम लोग डिसइंफेक्शन करते हैं तो और प्रोग्राम डालना तो इजी है, जैसे कि और डिसइंफेक्शन करना है, क्लीनिंग मेनू में गए, अप एंड डाउन किया, और डिसइंफेक्शन गए, कंफर्म किया, प्रोग्राम स्टार्ट हो गया। लेकिन यदि फ्रेंड डिसइंफेक्शन करना हो तो बहुत सारे स्टेप फॉलो करने होते हैं। तो उसके बारे में थोड़ा सा बताएंगे आगे। प्रेस इसमें है प्रेस क्लीनिंग की एंड सेलेक्ट क्लीनिंग, सेलेक्ट ट्रीटमेंट या रेंज जो भी करना है। मशीन अलार्म, कनेक्ट, डिसइंफेक्टेंट, डिस्प्ले। इसके बारे में मैं ये थ्योरी पढ़ने के बजाय एक वीडियो दिखाना चाहूँगा, शॉर्ट वीडियो, तो शायद ज़्यादा अच्छा समझ में आएगा। इफ ब्लीच डिसइंफेक्शन रिक्वायर्ड फॉर ब्रेड लीक, रेंज मशीन फॉर 15 मिनट्स। टेस्ट फॉर रेसिडुअल ब्लीच यूजिंग क्लोरीन टेस्ट स्ट्रिप ऑन कंप्लीशन ऑफ साइकिल। मतलब इसके अंदर भी रेसिड्यू टेस्ट करना है। यहाँ पे जो बोतल देख पा रहे हैं, ये 500 ml की बोतल में सोडियम हाइपोक्लोराइड फ्रेश बनाया हुआ है। फ्रंट डिसइंफेक्शन के बारे में आप देखा, तो इस तरह से हम फ्रंट डिसइंफेक्शन करते हैं। तो इसमें बीच में एक था कि जब दोबारा से पिकअप स्टिक अंदर डाला था, तो उससे पहले मैसेज आता है मशीन के ऊपर कि योर डिसइंफेक्शन जो स्टिक से नॉट कनेक्टेड, तो आपको वो कनेक्ट करनी है, उसके बाद जस्ट मशीन डिसइंफेक्शन में चली जाती है। तो इसके अंदर मैंने एक आपका एक टैबलेट करने की कोशिश करी है सारे प्रोग्राम्स के साथ, सारे जो आप डिसइंफेक्टेंट हम यूज कर रहे हैं उनकी प्रॉपर्टीज के साथ में, कि कौन सा केमिकल यूज करते हैं और क्या एक्शन है इसके बारे में। तो सिट्रोस्टिल की बात करेंगे तो इसके अंदर सिट्रिक एसिड, मैलिक एसिड एंड लैक्टिक एसिड, एंटी माइक्रोबियल एक्शन, हीट डिसइंफेक्शन एट 84 डिग्री सेंटीग्रेड, डिकैल्सिफाइंग ये करता है, क्लीनिंग इतनी अच्छी आपको सिट्रोस्टिल में नहीं मिलेगी, जनरल क्लीनिंग इफेक्ट लिमिटेड है। स्टोरेबिलिटी आफ्टर मैन्युफैक्चर, मतलब बनने के बाद 2 साल तक आप 5 to 25 डिग्री सेंटीग्रेड पे आप इनको स्टोर कर सकते हैं। ऑर्डर ऑलमोस्ट ऑर्डरलेस होता है सिट्रोस्टिल। टेस्टिंग ऑफ रेसिड्यू डिसइंफेक्टेंट नॉट रिक्वायर्ड, क्योंकि एसिड्स हैं फ्लशिंग रिंसिंग से निकल जाते हैं, आपको रेसिड्यू टेस्ट करने की जरूरत नहीं है। डाइल्यूशन 1.24 का यूज होता है, 1 ml डिसइंफेक्टेंट एंड 24 ml आरओ वाटर। कंजप्शन 4008 विदाउट डायसेप प्लस, विद डायसेप प्लस, मतलब हम कर रहे हैं डिसइंफेक्शन तो कितना यूज होता है अप्रोक्सीमेटली एक सेशन में। तो यदि विदाउट डायसेप प्लस की मशीन है आपकी तो उसमें अप्रोक्सीमेटली 50 ml यूज होगा, और यदि डायसेप प्लस 4008 है तो 66 ml यूज होगा। कंजप्शन 4008 ऑनलाइन प्लस एंड 5008 है 5008s, ऐसे ही अप्रॉक्स 82 ml, 96 ml और 90 ml। इससे आप अंदाजा लगा सकते हो कि कितना केमिकल यूज होता है और कितने दिन हमारे एक 5 लीटर का कैन चलेगा। इसके बाद नेक्स्ट है प्यूरिस्टिल प्लस, जो कि कोल्ड डिसइंफेक्शन जिससे हम करते हैं। पैरासिटिक एसिड है एक्टिव इंग्रेडिएंट, हाइड्रोजन पेरोक्साइड, कोल्ड डिसइंफेक्शन एट 37 डिग्री सेंटीग्रेड एंड डिकैल्सिफिकेशन यस करता है। क्लीनिंग लिमिटेड इफेक्ट है। स्टोरेबिलिटी आफ्टर मैन्युफैक्चर 2 ईयर एट 5 to 30 डिग्री सेंटीग्रेड। ऑर्डर की बात करें, फेंट ऑर्डर ऑफ एसिटिक एसिड, क्योंकि एसिड है तो फेंट ऑर्डर ऑफ एसिटिक एसिड। टेस्टिंग ऑफ रेसिड्यू डिसइंफेक्टेंट विद पोटेशियम आयोडाइड स्टार्च पेपर, जो कि पोटेशियम आयोडाइड स्टार्च पेपर बहुत सारे ब्रांड्स के साथ आते हैं, ये उससे हमको रेसिड्यू चेक करना है। यूडाइसन 1+24 है, और कंजप्शन प्यूरिस्टिल की है तो अप्रोक्स 4008 विदाउट डायसेप में अप्रोक्स 50 ml और विद डायसेप में 66 ml। कंजप्शन 4008 ऑनलाइन प्लस में 82 ml, 5008 में 96 ml, 5008s में 90 ml। लास्ट में एक्सपोर्टल है, एक्चुअली ये हम कंपनी मेड यूज नहीं करते हैं, अपने आप से बना हुआ फ्रेश बनाते हैं। तो सोडियम हाइपोक्लोराइड है, इसको भी कोल्ड डिसइंफेक्शन ही है क्योंकि 37 डिग्री सेंटीग्रेड पे होता है। डीगैसिफिकेशन कोल्ड डिसइंफेक्शन में, इसमें सोडियम हाइपोक्लोराइड फ्रंट डिसइंफेक्शन में नहीं होता है। एंड क्लीनिंग इफेक्ट एक्सीलेंट है। सो लॉन्ग इनएक्टिविटी के लिए आपको कभी करना है तो मतलब फ्रंट डिसइंफेक्शन वैसे भी इसीलिए रिकमेंड करते हैं 1 से वीक। हम रेगुलर यूज क्यों नहीं करते फ्रंट का, क्योंकि अब देख रहे हो सोडियम हाइपोक्लोराइड केमिकल है, या अंदर का जो सारा जो उनका इंटरनल हाइड्रोलिक्स है वो सारा जनरली सिलिकॉन मेटल का बना होता है। यदि इसको रेगुलर यूज करेंगे तो डिग्रेडिंग होगा, मतलब जैसा कि आप कोरोना के अंदर देख सकते हो सोडियम हाइपोक्लोराइड ने हर चीज का कलर चेंज कर दिया है। तो लॉन्ग यूज आप सोडियम हाइपोक्लोराइड का रिकमेंड नहीं है, डेली यूज में आप नहीं कर सकते। एंड क्लीनिंग एक्सीलेंट इफेक्ट है। स्टोरेबिलिटी आफ्टर मैन्युफैक्चर 12 मंथ, एक्चुअली ये कंपनी मेड का है तो ये हमारे ऊपर एप्लीकेबल नहीं होता है। एंड ऑर्डर फेंट ऑर्डर ऑफ हाइपोक्लोराइड एंड टेस्टिंग ऑफ रेसिड्यू, इसके लिए भी जरूरी है विद द पोटेशियम आयोडाइड स्टार्च पेपर, क्योंकि आपने देखा होगा हर प्रोग्राम में लास्ट में रिंसिंग है। एक्चुअली कंपनी के द्वारा पहले से रिंसिंग का प्रोग्राम डाला हुआ है, तो जनरली हर डिसइंफेक्शन के बाद टेस्टिंग करना मतलब उतना जरूरी नहीं है, क्योंकि ऐसा केस जनरली नहीं होते हैं कि उसके बाद डिसइंफेक्शन के बाद आपको केमिकल बचेगा उसमें रिंसिंग के बाद में। तो यूडाइसन 1+34 है। कंजप्शन 4008 विदाउट डायसेप प्लस 37 ml एंड विद डायसेप प्लस 49 ml। कंजप्शन 4008 ऑनलाइन प्लस अप्रॉक्स 61 ml एंड 5008 में 72 ml, 5008s 65 ml। तो ये जनरल इंफॉर्मेशन देते हैं तीनों ही केमिकल्स की वास्तव में होता क्या है, कौन से में क्या होता है। अब उसके बाद थोड़ी सी बात करेंगे क्लीनिंग ऑफ द एक्सटर्नल सरफेस ऑफ डायलिसिस मशीन। इंटरनल डिसइंफेक्शन हमने कर लिया, मशीन का बाहर का डिसइंफेक्शन भी करना है, तो कैसे करना है? क्लीनिंग शेड्यूल आफ्टर ईच सेशन एंड परफॉर्म विद क्लीन क्लॉथ और एथेनॉल बेस्ड डिसइंफेक्टेंट वाइप्स। मतलब एथेनॉल बेस्ड डिसइंफेक्टिंग वाइप से आपको क्लीनिंग करनी है आउटर सरफेस की, खासकर फोकस करना है जहाँ पे आप ज्यादा टचिंग करते हो, मतलब फ्रंट पैनल पे, क्योंकि मल्टीपल टच होते हैं, आप रियर में टच नहीं करोगे मशीन को, लेकिन वहाँ क्लीनिंग वहाँ भी करनी है, लेकिन ज्यादा फोकस करना है। और टेक्निक क्या होनी चाहिए? ओनली केवल डिसइंफेक्टेंट डाल दिया और ऐसे हल्का सा ऐसा रबिंग टेक्निक, फ्रिक्शन एंड रबिंग टेक्निक से सफाई करना है। क्लीनिंग परफॉर्म यूजिंग फ्रिक्शन रब एंड द सरफेस इज अलाउड टू ड्राई एयर। Machine should be disinfected thoroughly, including the front panel, intravenous pole, the side, back, and base of the machine. यदि ब्लड स्टेन्स है तो ब्लड स्टेन साफ करने के लिए अदर वाइप्स का यूज करोगे, एंड जनरल क्लीनिंग के लिए अदर वाइप्स का यूज करोगे। और यदि बहुत ज्यादा कई बार होता है कि आपने बहुत सारा ब्लड गिर गया मशीन के ऊपर, तो उसके लिए आपको फिर स्पिल मैनेजमेंट करना पड़ेगा, सोडियम हाइपोक्लोराइड का यूज करके, सोप करके, वो अदर थिंग। डिसइंफेक्शन ऑफ द डायलिसिस रूम, मतलब आप मशीन का हो गया, मशीन डायलिसिस रूम का भी थोड़ा बहुत आपको साफ सफाई करना पड़ेगा, वहाँ भी बैक्टीरियल ग्रोथ हो सकती है, फंगल इन्फेक्शन हो सकता है। तो द फ्लोर शुड बी वेट मॉप विद सरफेस डिसइंफेक्टेंट कंटेनिंग 5% कार्बोनिक एसिड, डाइल्यूटेड करते हैं, डाइल्यूटेड 5% कार्बोनिक एसिड आफ्टर ईच डायलिसिस शिफ्ट। ड्यू टू पैंडेमिक नाउअडेज वी आर यूजिंग 1% सोडियम हाइपोक्लोराइड सॉल्यूशन फॉर फ्लोर क्लीनिंग। अभी हम हाइपोक्लोराइड यूज कर रहे हैं 1%, कार्बोनिक एसिड 2 साल से नहीं किया है। Walls of anti room disinfect with 5% carbonic acid or 1% sodium hypochlorite solution on daily basis. Walls की बात करें तो walls actually disinfect with 5% carbonic acid और 1% sodium hypochlorite। अभी ये भी walls भी 1% sodium hypochlorite से ही कर रहे हैं। अभी every morning में, हर morning में कराना है। डायलिसिस स्टेशन डिसइंफेक्शन चेकलिस्ट, तो आप ये चेकलिस्ट है कि आपका डायलिसिस का कंप्लीट हो गया, उसके बाद आपको प्रिपरेशन करना है, डिसइंफेक्शन के लिए तैयारी करनी है, तो उससे पहले क्या करना है? तो उसमें ये पॉइंट्स हैं, परफॉर्म द हैंड हाइजीन एंड डन पीपी, मतलब पीपी एंड डिस्कनेक्ट द यूज्ड बेल्ट ट्यूबिंग एंड डायलिसिस फ्रॉम डायलिसिस मशीन। जो कनेक्टेड है सारा मटेरियल डायलिसिस ट्यूबिंग एंड डायलिसिस को डिस्कनेक्ट करिए एंड डिस्कार्ड ट्यूबिंग एंड डायलिसिस इन द लीक प्रूफ कंटेनर। Check that there is no visible soil or blood on surface। वहाँ पे यदि विजिबल सॉइल है और ब्लड है सरफेस पे, तो पहले उसको ट्रीटमेंट करना होगा। Ensure that the priming bucket has been emptied। जनरली जो हम प्राइम करते हैं वहाँ पे बकेट भी यूज करते हैं, तो उसको अभी आपको क्लीनिंग करना है। प्राइमिंग बकेट हैज बीन एम्प्टीड एंड सो द पेशेंट हैज लेफ्ट द डायलिसिस स्टेशन। ये भी इंश्योर करना है कि पेशेंट को हमने शिफ्ट कर दिया है मशीन पे, मतलब बच्चा बेड पे ही आप डिसइंफेक्शन मशीन का करने स्टार्ट उस टाइम पे नहीं करना है, थोड़ा सा टाइम देना है, उसको शिफ्ट करना है, क्योंकि हो सकता है आप मशीन के साथ में बच्चे का भी डिसइंफेक्शन कर दो। डिस्कार्ड ऑल सिंगल यूज सप्लाईज, सभी जो भी सप्लाईज हैं जो डिस्कार्डेबल है उनको आपको थ्रो करना है। रिमूव ग्लोव्स एंड परफॉर्म हैंड हाइजीन। लास्ट में क्या करना है? ग्लोव्स उतार के हैंड हाइजीन, जो हैंड हाइजीन तो हर चीज में है, करना ही है। इसके बाद हमने देखा कि पेशेंट शिफ्ट हो चुका है, उसके बाद आपको स्टेशन का डिसइंफेक्शन करना है। इसके अंदर आया कि स्टेशन का डिसइंफेक्शन कैसे करेंगे। परफॉर्म द हैंड हाइजीन अगेन एंड डन ग्लव्स, अप्लाई डिसइंफेक्टेंट टू ऑल सरफेस ऑफ डायलिसिस स्टेशन बाय यूजिंग ए बाइपिंग मोशन विद फ्रैक्शन। ensure surfaces are visibly wet with disinfectant। अच्छे से वेट होनी चाहिए। अलाउ सरफेस टू एयर ड्राई, disinfect all surface of emptied priming bucket, allow the bucket to air dry, keep used or potentially contaminated item away from the disinfectant sources। मतलब जो भी contaminated item है आपको वहां से हटाना है तुरंत। remove gloves and perform head hygiene। तो ये स्टेप्स हैं एक्चुअली बिफोर पेशेंट हटने के बाद डिसइंफेक्शन करने से पहले और बाद में, आपको चेकलिस्ट के टाइप पे हैं, ये फॉलो करने चाहिए। इसके बाद ये गाइडलाइंस हैं जो कि खास करके HIV और SCV और उनके रिगार्डिंग है। तो इसमें ये कैनेडियन स्टैंडर्ड एसोसिएशन की गाइडलाइन 2013 की है। ये कहती है कि ऑल ये इंटरनल पाथवे कैसे करना है इसके बारे में। ऑल पेशेंट रिगार्डलेस ब्लड बॉर्न डिजीज के रिगार्डिंग यदि कोई पॉजिटिव है तो इंटरनल पाथवे डिसइंफेक्ट बिटवीन ईच पेशेंट। ये गाइडलाइन कहती है कि कि हर उसके बाद में आपको करना है, स्पेशली कुछ अलग नहीं करना है, डिसइंफेक्ट बिटवीन ईच पेशेंट, चाहे वो HIV का है या HCV है या हेपेटाइटिस बी का है, ठीक है, डिसइंफेक्ट बिटवीन ईच पेशेंट। इसके बाद कैटेगरी 2008 वेरिएंस फॉर HCV प्लस पेशेंट, नो नीड टू डिसइंफेक्ट बिटवीन पेशेंट अनलेस ए ब्लड लीक हैज अकर। ये गाइडलाइन कहती है कि नो नीड टू डिसइंफेक्ट, मतलब आपको बिटवीन पेशेंट्स के मतलब पेशेंट के बीच में भी आपको डिसइंफेक्ट करने की जरूरत नहीं है हर पेशेंट के बाद। If blood leak has occurred, disinfect internal pathway and dialysis to dialyzer connector. Dedicated machine not required. डेडिकेटेड मशीन नहीं चाहिए, अलग से मतलब नहीं जरूरत है। यूरोपियन रीनल बेस्ट प्रैक्टिस गाइडलाइन 2009 HCV प्लस पेशेंट रेस्पॉन्ड टू कैडिगो गाइडलाइन, सपोर्ट कैडिगो गाइडलाइन को सपोर्ट करते हैं भी। कैडिगो 2015 HCV पेशेंट सपोर्ट कैडिगो गाइडलाइन। इसके बाद स्टैंडर्ड यूके रीनल एसोसिएशन 2007 HB hepatitis B and HIV dedicated machine not required, standard disinfection protocol between patient। ये कहते हैं कि डेडिकेटेड मशीन नहीं चाहिए, आप स्टैंडर्ड जो डिसइंफेक्शन प्रोटोकॉल जो हम यूज कर रहे हैं वही करिए। और हेपेटाइटिस बी के लिए यूज सेपरेट मशीन, रिकमेंडेशन है यूके रीनल एसोसिएशन 2007 कि use separate machine for hepatitis B infected patient, can use for non-hepatitis B patient if machine decontaminated including आपका Hansen connector and the pressure transducer, उस कंडीशन में आप यूज कर सकते हो, अच्छे से आपने उसको डिसइंफेक्ट किया है तो। कम्युनिटी एंड हॉस्पिटल इन्फेक्शन कंट्रोल एसोसिएशन कनाडा डायलिसिस 2007 HCV hepatitis C and HIV routine practice does not identify what routine practice means, मतलब जो हम कर रहे हैं वो जनरल डिसइंफेक्शन की जरूरत है, अलग से कुछ नहीं चाहिए HCV और HCV और हेपेटाइटिस बी के लिए। कैनेडियन सोसाइटी ऑफ नेफ्रोलॉजी फॉलो मैन्युफैक्चर रिकमेंडेशन फॉर फ्रीक्वेंसी एंड टाइप्स ऑफ क्लीनिंग एंड डिसइंफेक्शन, ये कह रहे हैं कि मैन्युफैक्चर जो बताता है वही करिए। तो थैंक यू। Any question, please?
Such a great detail machine. First of this session will be COVID dialysis during COVID pandemic.
What is the practice? What's the practice currently regarding hepatitis C अगर patient है? ये लोग कहते हैं कि अलग कमरे में होना चाहिए, क्या solution का क्या guidelines हैं, क्या करें?
Like to answer?
तो हम लोग क्या क्या करते हैं, वो हमारे जो ड्रिल का फट गया वो लग गया, ये ना हम से अलग कमरे में होना चाहिए। मशीन में तो तब कहते हैं फिजिकल आइसोलेशन ज़्यादा जरूरी है rather than hepatitis। What do adult units see and need of what kind of क्या करते हैं adult units क्या करते हैं? हाँ हाँ। System of dialysis centers, they use hepatitis B and HIV for physical isolation. For HCV, they don't. One more thing I would like to, for the interest of audience, I would like to add in this. So it has been mentioned there is a disinfection when we are doing with Purostil and hydrochloride. We do require to check
residual testing. And once we are using citric based chemical or citrostil, we don't require that. So what is the reason behind that? So for the interest of audience, would you like to answer this?
I don't know. एक्चुअली हम इसमें सोडियम हाइड्रोजन पेरोक्साइड है एक्चुअली ये रिलीज करते हैं आयोडीन क्लोरीन को और ये आपके मिथेमोग्लोबिन जो बताया है उसमें आपके हीमोग्लोबिन में आता है जो कि मिथेमोग्लोबिन बनाता है और वो कैरी ऑक्सीजन का कैरी करना बंद कर देता है। सो क्योंकि ये एसिड रह जाता है क्लीन नहीं हो पाता है इसलिए आपको रेसिड्यू टेस्टिंग करना है क्योंकि वो निकल नहीं पाता है आपके ड्रेंसिंग कई बार मतलब केवल क्योंकि ये कोरोसिव टाइप का वो है।
So adding to this, reason behind not to perform residual testing in citrostil or citric based chemical is citric जो है once blood is exposed with citric acid, it will convert into the bicarbonate. So we don't require if there is a citric acid is there, so we patient will not harm with that. So that is the reason. And using Puristil, it has having a acetic acid. Once acetic acid get exposed with the patient blood, it may basically start damaging the cell. So that is the reason for citrostil we don't require residual testing. Okay, and that residual testing has to be performed with a particular strip. That name is potassium iodine starch paper. Potassium iodine starch paper. Once we basically dip it with that drain thing, and it gets converted in blue or violet color. That is the reason. You are right. For parasitic based chemical, it reacts with the patient. And for citric based chemical, citric is indirectly, if patient gets exposed with that, it converts into the bicarbonate. So we don't require, we are not bothered about that. But once we are using Puristil or any kind of acidic based or parasitic based chemical, hydrogen peroxide also, like in certain manner, we don't get harm with that. So that I want to, for the interest of audience, I want to.
Any other questions? We can move ahead for the last topic in this session. Diabetes due to pandemic will be taken by Dr. Mustafa, the professor and in charge of Division of Pediatric Nephrology, Department of Pediatrics at LNJP Hospital. Dr. Mustafa.
Firstly, I must say Dr. Som took a very nice, Mr. Som took a very nice talk. And he has, I think, covered most of the disinfection part, even of the COVID pandemic, because 1% hypochlorite seemed to be the only thing, causing everywhere. There was a spray. So we had an entire year of holy spray of 1% hypochlorite. But one thing I realized that with 1% hypochlorite, it did bring down, sir, the sepsis and infection, because even in the COVID, I would be sharing that adult data and all that, we didn't see many sepsis patients or patients getting infected during hemodialysis. So I wondered whether that, the interdistance and the use of sterile sheets and possibly the hygiene measures that increased, so that it brought down the infection rate, and which we are now like seeing again a rise. So possibly that could have been of some benefit. So very briefly, first I would like to give you an overview of what the kind of patients we saw, and I had the good fortune of probably saying that I could work in both the pediatric nephrology and adult nephrology units, which helped me in broadening at least my horizons. So okay. So we all know that the COVID pandemic began from the city of Wuhan before becoming a global enemy, and has killed almost 51 lakh patients worldwide and about 4.64 lakhs in India. And the mortality was probably maximum during the first and the second wave. And in the third wave, fortunately, while the numbers were very large, the mortality, at least in our country, was not that much. And if you look at this from the point of pediatrics, probably, we were fortunate that COVID spared children. And if you look at the worldwide data, you'll see that amongst the deaths, as well as amongst the number of cases, it was less than 0.5% overall. And if you look at, this is the this age distribution of patients. This mouse will not play on this. It's not being seen on the screen, no? Is there a way? Or if you have a pointer which works on the screen, will it work? Hey, mouse to have, but it's not showing because I'm seeing that screen actually for the purpose of. Okay, sir. I think इसी में खुल जाएगा sir. I think yeah. And if you look at the age distribution of most patients, it was between 20 to 6. Like most of them were between 20 to 60 years of age. And if you look at the pediatric data, it is less than 7%. Patients and the patients below the age of 18 years or so. And if you look at the mortality data also worldwide, it was less than 0.3% of all adult and pediatric deaths combined. So that way, probably we were fortunate to not see too many patients. And there have been some reasons now proposed that why children were relatively spared of COVID. Possibly they have lesser number of ACE2 receptors. They have having a new system, they have a lower propensity for endothelial damage and hypercoagulation, cross immunity because of repeated viral infections and other variants of coronaviruses also provide some kind of cross immunity. And they have higher melatonin level. Bat is the only mammal which has the highest amount of melatonin. So possibly as it acts as a reservoir, melatonin too acts as an anti-inflammatory. It has antioxidative properties, and there have been some recent studies where they have looked at the melatonin levels in children with COVID and non-COVID pneumonias, and they found that they had equally high levels as compared to adults. So this could have been a protective factor. Now, if you look at the impact of COVID on the kidneys, we saw that there was a sudden new increase of onset of AKI, and there was a worsening of the stages of patients with CKD also. There was more need of dialysis, especially during the first wave of the pandemic. And there was some new onset proteinuria, hematuria, and there was a some patients reported with, rapidly progressive GN, collapsing glomerulopathies, and even recent onset TMA was also seen in patients with COVID infections. And very rarely ANCA-associated vasculitis and recurrence of anti-GBM disease has also been reported. And now this has been reported after COVID vaccinations also worldwide. So there could be an immunogenic process involved in that too. So if you look at the overall incidence of COVID AKI, it was about 20% amongst all patients that were hospitalized, and the incidence was much higher in patients who were admitted to the ICUs. And the proposed mechanisms for this occurrence of this COVID AKI was probably a direct cytopathic effect of the SARS-CoV-2 virus. And there were some post-mortem series of patients of dying of renal dysfunction and COVID from China in the initial part. And if you look at this biopsy, this is an electromyograph of the biopsy specimens, and you look at most of the coronaviruses are located in the proximal tubule. This is the distal tubule where there are fewer in number, and also some of them in the podocytes and the food processes of the podocytes. So possibly it was causing more acute tubular necrosis followed by a glomerular kind of diseases that were reported rarely, less commonly. So if you look at the mechanisms of AKI, it was not just related to the SARS-CoV direct cytopathic effect, it was the medicines, not just the antibiotics, but antivirals like remdesivir and other antiviral agents, and even HCQS for that matter, that was being used as an antiviral agent at that point of time. The endothelial damage, the hyperinflammation, which was more prominent with the Delta strain during the second wave of the disease, and some amount of muscle damage also, because this muscle damage was very prominent in the second wave of the disease, where the levels of LDH and muscle destructions were much higher in the patients, and patients were actually losing the chest muscle mass and all, and which was contributory factor for respiratory failure as well. And toxic myocarditis also we saw more during the second wave. So possibility of a higher incidence of AKI was not just related to the cytopathic COVID virus, but also because of the multifactorial etiology. And if we look at the overall, these are various adult series where they have looked at the incidence of AKI in the patients of COVID. And so the most of these series showed that the mortality was much higher in patients who had COVID AKI as compared to the patients. It was almost double. If you look at the series from US, there was 50% mortality with AKI in COVID positive patients, and the highest mortality reported was around 60% from the COVID hospitalized patients from the UK series. So overall, the message is that if you have a COVID patient and if he's hospitalized, and if he also has an underlying AKI, the need of renal replacement therapy would rise, and most of these patients would require dialysis, not only in the ICUs, but also in the hemodialysis units attached with these units. So very briefly, I'll share our own experience first of the pediatric and then of the adults while handling these patients. During the first wave of the pandemic, because my hospital became a COVID-only hospital right in the beginning of the wave and in the month of March. And from April to November 2020, we saw about 19 patients with underlying renal condition and COVID-19 positivity. And if you look at the profile of these patients, 10 were CKD, 5 were AKI, new onset AKI, and 4 patients had underlying nephrotic syndrome. And if you look at that, 2 patients died, but these patients were the patients who developed new onset AKI. And if the cause of AKI was not entirely COVID in these patients, it was sepsis in a majority. And if you look at the mean duration of hospital stay, that was around 11 days. So which was comparable to the viral shedding even in the adults, which was around 7 to 10 days in the first wave of the disease. And when we looked at the all COVID positive patients who were admitted during the same period in the pediatric wards, about 185 patients were admitted between June and December 2020. And if you see, majority had a mild infection, and most of them, the ones who had moderate to severe disease, they required oxygenation, which was primarily by either an NRM or a Venturi mask. And the mean hospital stay was 7 days, which was much lower than the adult nephrology patients which stayed admitted for us. I'll be sharing that data a little later. And even the mortality was around 3.7%. So it was much lower than the adult mortality. And these were some of the series that were published during that time, during the peak of the pandemic in Europe. And if you see that the number of patients, even in the pediatric units, was quite less. The UK registry reported about 5 patients. Then there was the study from Gosh, where amongst patients hospitalized with COVID-19, 29% had AKI, but none of them required actually a renal replacement therapy or dialysis. Then the Spanish study, where 16 children were reported with COVID positivity and underlying renal condition, and most of them, could be managed from the OPD itself. And then there was this survey of the Italian Society of Pediatric Nephrology during the peak of the pandemic. And from this, they surveyed these patients of renal diseases through telephone and all, and then they realized that the positivity rate for SARS-CoV was only 0.19%. So somehow, even children with renal diseases were protected of COVID as compared to the adults. And this is the data from AIMS, MAMC, CNBC, and Safdarjung, where, this is a retrospective data covering the first and the second wave of the disease. And 88 children with renal diseases tested positive, out of which almost half required hospitalization, and roughly 20% had a moderate to severe disease. And if you look at the mortality, it was way lower than that of the adult mortality. It was about 3.7%. And if you look at the median hospital stay of these patients, it was around 10 days. And the time to RT-PCR negativity in this subgroup was somehow around 2 weeks. So patients who have an underlying renal disease probably shed the SARS-CoV-2 virus for longer periods of time. And this is important because many of us who would be handling the dialysis units of such patients, we expect that the patient who has become positive on that day will at least become negative after the first 2 or 3 weeks. So we need to follow those PP precautions and all, and in dialyzing them also would be kind of this thing. This was a study that we published on 10 CKD patients who were children and young adults. And the young adults, we realized, tend to behave almost like children, like their mortality was lower and the viral shedding was also similar. So the large part of my data was the adult data, where we looked after the adult CKD patients for almost a year's period. And during the month of June to November 2020, about out of the 283 admissions to our unit, 222 were with CKD and the remaining were AKI. And of these CKD patients, about 165 were on maintenance dialysis. And most of the patients who were being referred from different dialysis units, like those who were on even 3 times maintenance dialysis, had actually reduced the dialysis time to 2 times a week. And that was primarily because there was, like most dialysis units outside, were actually asking the patients to come with the RT-PCR negative report each time. It was not even weekly, it was each time in the private sector. So that had become very difficult for the patient. It added on to the cost of dialysis, plus the hassle, and most of the reports during the peak of the pandemic were taking more than 24 hours to arrive. So that most of the patients themselves had reduced their dialysis frequency to about 2 times per week. And if you look at the profile of these patients, the median age was 51, and the oldest person that we dialyzed was about 85 years lady. So 86% were symptomatic, but we were admitting even asymptomatic patients at that point of time, because most patients who required dialysis in our units, they had to come from home. And if they were coming from home and shedding the virus in the public transport, coming to the hospital from all kind of gates and not following the protocols, it would have led to more viral shedding. So in fact, it was not given in the government guidelines, but it was actually understood that if any patient has a maintenance dialysis need, he should be admitted in a COVID hospital, which is managing patients with hemodialysis, and they should stay there till they are non-shedders, because if they have to come for repeat dialysis, they should be negative. And majority of them, as they had fever, cough, dyspnea. These were the symptoms, and about 15% also had initially diarrhea. And if you look at the vascular access, as we had seen the data from pediatric series, most patients are on central venous catheter uh, dialysis, but here almost 94% had a functioning AV fistula, and they were on already on 70% of them were on a twice a week dialysis during the just preceding of the COVID wave, and almost two-thirds were requiring oxygen and had moderate to severe disease. So most of our patients had a moderate to severe course during the COVID pandemic, and this is the data that we have published recently. And if you look at the salient features of this data, the NL ratio of these patients was high when they came to us also. Neutrophil to lymphocyte ratio served as an important marker to look at the progression of this disease, and in deceased it was around 8.8. And apart from that, if you see that the total admission days was around 2 weeks in most of the patients, and if you look at the RT-PCR negativity, that was about 2 weeks, and 50% of these patients took more than 2 weeks for becoming negative, and even 20% were positive even after 3 weeks of hospital stay. And the mortality amongst these patients, if you see, was around, overall mortality was 20.4%, with about 22, I have not able to read myself, 22.4% versus 23%. So it was on an average much higher than the patients that were, like admitted at that point of time in the hospital. And the amongst the drugs that we use, HCQS was used in a majority, and azithromycin in a smaller number of patients. One experience that I would like to share is that when we used HCQS and azithromycin together, we saw a lot of bradycardia and prolonged QT intervals. So we stopped using azithromycin along with HCQS, and by that time there were some studies where ivermectin was also being used. So we added that, and it was a part of our own hospital drug committee as well as the national guidelines. And two-thirds of them also required low molecular weight heparin and steroids for the treatment of COVID infection. And most of these patients, when we were giving them low molecular weight heparin, so if they were on dialysis, we were using either a low heparin dose dialysis, or we were using no heparin dialysis for these patients. And amongst the associated conditions that we had with these patients, roughly one-third had type 2 diabetes mellitus, and most of them were on insulin. And one thing which we also learned through these working in these adult nephrology unit was that most of your anti-diabetic drugs are excreted through the kidney. And as your GFR falls, especially if you are in stage 4 or stage 5, their serum levels become very labile, and you tend to have multiple episodes of hypoglycemia. Therefore, most patients who are in CKD 4 or 5, they're actually on insulin, and their insulin requirement also goes down to about 0.3 to 0.5 unit per kg instead of traditional 1 unit per kg that we are usually using in these patients. And if you look at the Hep C, Hep B positivity rates, they were quite low. So it's not that because of the probably appropriate Hep B vaccination and all, most patients do not, we don't see that much of Hep B positivity, and some of them also had an underlying chronic liver disease. So this is the overall mortality rate of about 21.2% in our adult CKD patient, and this was almost double of the remaining hospital mortality. The data of about 10,500 hospitalized adults from Loknayak was published, and in that the mortality rate was around 13.7%. So, word about the antivirals to be used in these CKD patients. When the pandemic began, we were very underconfident regarding the use of remdesivir in the CKD unit. But as you know, like most of the guidelines were recommending HCQS, azithro, HCQS, ivermectin, then ivermectin alone, and then no ivermectin. So there was no clarity regarding the use of what was working and what was not really working. But then came, and the reason primarily being that the evidence was very less. And if you look at most of the trials that were, looking at the RCTs or regarding the therapies for COVID infection, most of them had actually excluded CKD patient. Even the recovery trial on steroids use of COVID-19 had only 8% of the patients with chronic kidney disease. So they had left it to the individual physician's decision that what antivirals to be used in these patients. And again, there was an issue of whether to use dexamethasone or methylprednisolone as a steroid. During the first wave of the pandemic, Dexa was working very well. But during the second wave of pandemic, we did find that after 2 to 3 days of Dexa, also the inflammatory markers were really very high, and there was a better response to methylprednisolone. And then there came 1 or 2 studies also which showed that there was slightly better improvement with methylpred. So in most of our units, we started using methylprednisolone in almost all patients. Then Regarding the need of, because I believe that most of these studies, I'll be talking about the remdesivir data also, most of these studies had used antiviral agents when the patient had become oxygen dependent. And to me, I feel that most of the antiviral actually should have been given in the much earlier part. So possibly because most patients who were getting hospitalized were the ones who needed oxygen. So possibly that is why when we say that it was not working or working less, because if you look at our CKD patients, they were shedding the virus for the first 2 to 3 weeks also. So if you use antiviral in them in early stages, probably you'll end up avoiding hospitalizations and worsening of the viral viruses. But we don't have much data on that. But this is some of the hypothesized those reasons. But because the hyperinflammation part usually begins after the first 2 weeks, and where you would be using steroids. There were studies of use of tocilizumab, etc. also. But since most of these CKD dialysis patients are already on dialysis, you won't be using tocilizumab and all, because it may tend to worsen it may act as a predisposition to sepsis and all that. So there was hardly any data on the use of tocilizumab or even plasma. In fact, plasma was also contraindicated, at least at our center, for patients used in CKD. So we hardly had anything in arsenal against, the COVID infection. And this was a Cochrane review that was published regarding the utility of ivermectin, and it concluded that it was of uncertainty about the efficacy of use of ivermectin either as a prophylaxis or for treatment. So at that point of time, when we were not sure of whether to use remdesivir or not, this study came from KEM Mumbai, where they used remdesivir in patients of acute kidney injury as well as chronic kidney disease, and about 46 patients. While their mortality tended to be high, but we were bothered about the liver functioning, because the problem with remdesivir is that it is a highly water insoluble drug, and the SPECD carrier protein, which is used for improving the solubility, that is primarily, it's excreted by the kidney. So once your GFR falls, the SPCD carrier level, sulfobutyl ether cyclodextrin levels increase in the blood, and it is primarily a hepatotoxic agent. And so if the levels rise too much, it can cause acute liver failure also. So in their study, it was heartening that if the patients were on dialysis, the LFTs never, for none of the patients, they went up to more than 5 times the upper limit of normal. So this gave us some confidence, and we started using patients who had at least a GFR of above 30 ml. We started using remdesivir in half doses, in doses of 100 mg daily for about 3 to 5 doses, and especially in the patients who had transplants and they landed up with COVID infection at our place. Then there was another study. This was from the medical college in Chennai. It's from Chennai Medical College, where they used remdesivir in patients who were on hemodialysis, 48 patients, and they gave the drug 4 hours prior to dialysis to bring down the levels of SBECD. And they found a significant benefit, and the duration of hospitalization and admission and even the oxygenation duration got reduced in these patients. So looking at the benefits, it looks like it can be used in patients with CKD. And again, there was one study for the use of favipiravir in children with CKD. And here, most of the AKI that occurred in these patients was because of, multi-inflammatory systemic inflammation of childhood and because of MESC. And they did use favipiravir, and they had to use remdesivir also in 2 patients. And overall, the outcome was good, because out of 11 patients, 10 could be discharged with recovery of AKI. So it seems that these antiviral agents should work in patients with chronic kidney disease also. Again, some of the adult data on patients with chronic kidney disease and hospitalized with COVID. And across all these series, if you look at, the mortality is pretty high, ranging from 11.6% to almost 30% in one series. In fact, this was a large survey of adult CKD dialysis units from Brazil, and they found that the incidence, mortality, and fatality due to COVID-19 infection in these dialysis units was as high as 5.1, 33.4, and 6.4 times as compared to the general population who was having COVID-19 infection. And again, if you look at the gist of this slide, study from Korea, where there are only 14 CKD patients, but then this is a large series from Turkey, where 47 centers had been surveyed. And if you look at that, again, the mortality varied from 21. Was around 14%, and most of the centers were again using drugs like HCQS or stalmivir was there in the initial part, when there was a confusion with H1N1, etc., and favipiravir use also. And in fact, 2 recent studies that were published from India, where they have looked at the COVID-19 infection in hemodialysis units. In fact, in this first study that was published from 11 centers, where they looked at the COVID positivity in the hemodialysis units, it was around 16%. So we were getting patients who were already COVID positive, but they were following up patients who were coming to their COVID units, and the positivity rate was around 16%. But if you look at the in both these studies, this is from the Chennai Medical College, the mortality was lower than our series, but possibly because here in the second series, 50% of these patients were asymptomatic. So possibly that was the reason for lower mortality in these patients, while most patients which were admitted to my hospital, almost 80% were symptomatic, and they had a large moderate to severe disease. And if you look at the results of European registry, and this is from all adult data, you can see that in post-transplant patients, within the first 28 days, mortality after post-COVID-19 infection was around 20.2%, and which compared to around 0.2% for those who did not have COVID-19 infection. And similarly, for the dialysis patients also, it was around 21.2% compared to 1.3%. So there was a general conclusion that pandemic had been very bad for patients who were on dialysis or those who had undergone transplant. In fact, some centers, the initial guidelines had said that you delay the transplant till the COVID-19 pandemic goes off. But as the virus was having an intermittent course, we did get confident people were getting transplanted during the second wave of the pandemic also. So our own Indian guidelines, we had the Indian Society of Pediatric Nephrology guidelines, and the hemodialysis part was actually an adaptation from the GOI guidelines only. And the gist of most of these guidelines was that patients on maintenance hemodialysis should not delay their dialysis. But because of the reasons that I told you, most patients already who were on 3 times the dialysis had reduced the frequency of dialysis. And initially we started with, educating the healthcare workers for regarding the symptoms of COVID-19 infection, and all the staff had to be taught, the use of PPE, the donning, doffing, etc., which was, I think, similar in almost of these centers. There should have been an adequate availability of sanitizers and adequate PPE, and all patients to wear surgical masks, sitting spaces to be at a distance of 2 meters. Now, the space again is a challenge in many centers which have small dialysis units, and they are mostly enclosed. You are having an AC system which is also circulating the air. So in the initial part of the pandemic, in fact, all the air conditioning of the CKD ward and dialysis units was actually stopped, and it was really terrible wearing that PPE. It was, at least for the residents, it was very difficult. But then there were HEPA filters that were installed in these units, and subsequently the air that was being cleaned, and also that again that challenge was met over a period of time. So the guidelines did mention that initially the guidelines said you keep a distance of 1 meter, but then they realized that the viral spread can occur up to 1.5 meters. So that is why the distance of 2 meters, would, at least if the patient is wearing mask, will reduce the transmission between the patient. And again, when Mr. Som was speaking about, the disinfecting the surface of the machine and all, because it's primarily a respiratory pandemic. So after each patient dialysis, possibly, you need to clean the machines with the sterilium and all, the front panel as well as back panel. Now, this again, there was, like the guidelines said in the initial part of the pandemic, that even when you are suspecting somebody who has symptoms of COVID, even in a non-COVID hospital, they should be dialyzed probably at the last session of the day or in the isolation room. But this facility again was not available at many places. And the other thing was that if you're handling such a patient without, this is what we realized, because many of our residents and staff nurses, they were becoming sequentially positive despite having adequate donning and doffing. So some kind of a break definitely occurs. So if you do it in the end of the day also, it will lead to the spread of pandemic itself in these dialysis centers. So possibly that is why most patients who were being tested positive were actually being sent to COVID only hospitals where dialysis was feasible, and they were being, so for us the spread between patients was not an issue because they were already infected and they were shedding a lot of virus because they were on NRM. Some of them were getting nebulized also and all that stuff. But for the purpose of reducing the transmission amongst the healthcare workers, the doctors, residents, the technical staff, the dialysis nurses, and the orderlies and all that. So for that purpose, there was a clear, the dialysis unit itself was kind of divided into the red zone and the green zone, while the nursing station and all the case sheets and everything was there in the green zone. The red zone was primarily a separate lift, a separate entry for the dialysis patients, and whosoever was entering that area was actually knew that this is a COVID positive area. So you had to don your PPE, and possibly shifts had to be of about 4 hours, because it was difficult to wear that PPE beyond 4 hours. So we would tend to divide, one nurse with one staff. So 4 hourly kind of dialysis shifts so that the patients could get dialyzed adequately, monitored also. But then they were we were banking more on, monitoring with these monitors, and rather than physically taking all the blood pressures again and again and all, because with PP you can't hear anything with the stethoscope, and even the communication with the patient often, they are not identifying you. Everybody is wearing PP, so they can't. Most of them were complaining, and the hospital was on television for almost all the wrong reasons in the initial part of the pandemic. So it was actually quite depressing. And so, these were some of the challenges. I'm just discussing them with these slides only because, again, he talked about the cleaning of surfaces and also cleaning of floors and all for 1% hypochlorite. And daily, after every 4 to 6 hours, just to reduce the viral titters in the environment, we were asking them to do 1% hypochlorite spray, specifically when we found that the other residents and even the healthcare staff was becoming more positive. So we thought that this strategy may work. So we started making it thrice to 4 times a day. And these were the GOA guidelines which are there, which were published in April 2020, where they talked about how to do disinfection, how to prepare. Most of these were I think almost, he has already told us, alcohol-based sanitizers should have at least 60% alcohol. So minimum 60% should be used. And then there was the list of PPE that was, most of us have become trained in doing that. But in the initial part of the pandemic, I remember somebody came to, when we first started with the COVID sensitization, somebody even taught us how to wear a N95 mask, because the way I'm wearing this mask, I don't think it can ever prevent. I'm just trying to just keep it like that. So if you touch your mask here on the surface, already you are not wearing it properly. So actually all those things which appear now, like very minuscule kind of things, were actually challenging even in the initial. And we had all videos being, being kind of sent to everybody, and we were just practicing. Even I took one PP home and practiced it at home, donning and doffing. I thought, which size I need a larger size. So all those issues were there when we were kind of going through that whole process. So again, there was this list of all kind of protective PP, how much was really required. Now, as we know that the COVID positivity rate in the community is right now very less in Delhi, less than 0.5%. So possibly whether I wear this mask or not, it's just okay. But if the positivity rate really rises to 10, 15, 20%, then I should be using N95 even at, interaction with the first interaction with the patient. A surgical mask will not do the job. And the same thing, depending upon if you are handling those patients and you know that they are COVID positive, you'll wear the full PP. So all these would be like dependent also on the proportion of patients who are getting dialyzed. And when we saw, I have many of the other country guidelines were also there, but I like this Canadian Society of Nephrology guidelines. They even spoke about the transportation services for HD patients because their system was getting overwhelmed. So they thought that instead of admitting those who have mild disease or asymptomatic and they have to come for dialysis from home, you should have an ambulance or some other vehicle, and you should have a person who's provided with adequate PP also to bring them and take them back to home. And they should not be allowed to go out during the intermittent period of dialysis, and only after 2 weeks of isolation they should be allowed to go out times. So but then it was a very challenging. We know that what kind of challenges we faced in our hospital itself, getting PP, getting the sheets and other things also. So it was not a feasible solution. So for us, the feasible solution was that any patient who requires maintenance dialysis or a new onset dialysis, he has to be hospitalized and he has to stay in the hospital till he becomes RT-PCR negative. So we were doing every 7 days, we were sending RT-PCR for these patients. So what lessons we learned out of this whole pandemic? We realized that kidneys did get affected a lot by this virus, and most of the patients with chronic kidney disease had a moderate to severe disease, and the use of antivirals was actually limited by the evidence that was available over there. But yes, we are more confident in using remdesivir in our CKD patients now, and steroids, especially methylprednisolone, did improve the respiratory outcomes. And I did realize that there should be, because we somehow repurposed ourselves overnight. So I think if there is a close coordination between pediatric nephrology and adult nephrology programs, and some of the diseases like diabetes, which are killers in adults, but we see it less commonly in pediatric patients. So some of the interspeciality managements we should be aware of. And then, even for the future HD units that will come in future, I think there should be more space for isolation, and we should try to have some waiting areas, maybe in the ground floors or somewhere, where there are open spaces, and you can have, instead of only areas where there is all complete air conditioning and all. And possibly one could consider plexiglass separators between two dialysis sessions. We never know if we keep having these recurrent pandemics. And again, larger waiting areas and spaces and all, and maybe restricting the number of people who come to the dialysis unit along with the patients. Maybe that could be some of the suggestions. Just some happy and like some memories of the COVID times, Diwali celebrations, muted Diwali celebrations. But with these, I just wish that we don't see these situations again. But then, learning from our experience, we should be like, a little flexible in repurposing one, and also, looking at those challenges and taking them in a positive stride, and try to, see some positivity out of it and try to manage that. So with this, I'll stop here, and thank you for a patient hearing.
Thank you, Muhammad. And thank you, Shobha ma'am and Suprita ma'am, for chairing the session. Before we go for lunch, I would like to announce that the certificates for the workshop will be circulated on email. So we break for lunch now, and we'll reassemble after 30 minutes or so. Thank you.
I think that's better. I'd just request everyone for a group photograph, if you could come downstairs right in front of Convergence facing the lawn side. On the stairs, we could have a group photograph before we go for lunch. Okay, thank you.
Thank you, Dr.
Pause.
Okay, welcome back after lunch. We have the third session for the day, which is going to be chaired by Dr. Abhijit Saha. He's a professor, Department of Pediatrics at Lady Harding Medical College and Associated Kalavati 7 Children's Hospital in Delhi. And along with him will be Lieutenant Colonel Dr. Aditi Sharma ma'am, consultant pediatrics and pediatric nephrology, who is an assistant professor in the Department of Pediatrics at Army Hospital, RNR, New Delhi. So I invite both ma'am and sir to chair the session.
Welcome you all in the post lunch session. Sorry. क्या हुआ? कुछ तो गड़बड़ हुआ. Okay. So welcome you all in this post lunch session. We have three lectures in this session. So without wasting time, I would like to invite Mr. Parvinder Tawar, and he will speak on dialysis using Fresenius 4008 units, which is, I think, the most used dialysis machine in most of the dialysis centers. So over to you, Mr. Parvinder. So good afternoon, team. So I would like to extend my gratitude and thanks to Dr. Aditi, Dr. Bagga, and team AIMS Delhi who give me opportunity to who give me opportunity to showcase this. So without further ado, let me start with. So we'll discuss today on 4008S machine. So I basically distributed this presentation in two parts. In first part, we'll discuss on what is the 4008S machine has, what are the features it has, and next in my presentation we'll discuss about the troubleshooting part. What are the alarms, how we will discuss this, how we elaborate this, how we diagnose this, and what are the things we as a dialysis technician or as a dialysis nurse we